So welcome to Chennai, first and foremost. I'm very glad to see you all here. So I think we are just on time. One of the speakers couldn't make it, but all the others are here. And one might be a recording that we'll have to play, but I'll walk you through it as we progress. The first session, everybody is here. So we'll start the first session. I'll ask Prafulla to introduce the moderators, and then we'll carry on. And the speakers, yeah, you're already in the first two rows, so that's good, because people will start coming in late and they'll sit in the back. So, yeah.
Good morning, everyone. Welcome to the pediatric intervention session on vascular anomalies. We are honored to have this session chaired by an exceptional panel of clinicians and academics with proven scholarly impact. First, I would like to welcome everyone. Dr. Vishal Nandakishore Bagre, senior interventional radiologist trained at Tata Memorial Hospital with peer-reviewed case reports and clinical research in endovascular embolization and vascular lesion management. He's a faculty and contributes to National IR educational and training program. I welcome you on dais. Dr. Harish Bujadi, Associate Professor of Interventional Radiology at PGIR, with over more than 100 scientific publications and a significant involvement in interventional oncology and endovascular research. His work appears in index journals and evidence-based radiology texts. I welcome you on dais. Professor Devra Anil Kashi Vishnuvardhan, Senior Consultant Interventional Radiologist with over 16 years of experience and multiple peer-reviewed clinical and imaging studies, contributing to evidence-based practice and minimally invasive diagnostic and interventions. Welcome you, sir. Dr. Priyanka Naranje, accomplishing radiologist and interventional radiologist with publications in pediatric imaging, interventional radiology, and respiratory imagings, including index studies on pediatric lung ultrasonography and CT versus MRI evaluation. Welcome you here, ma'am. We sincerely thank our chairpersons for their scholarly leadership and for guiding this important session.
A very good morning to all. To just lighten up the proceedings, let's just clap for all the speakers who are there and start this session.
Let's begin this session with the basics that set the stage for everything else. May I invite Dr. Chandra Mohan to walk us through the classification and pathophysiology of vascular anomalies. Welcome, sir.
Good morning. I was thinking it's going to be us talking to each other, but looks like there are at least 10 more people in the audience. It's a pleasure to be here in my hometown, so let's get this finished. So when Karthik asked me to talk on this, I gave the same talk last year in AOCR, so I thought it's easy, I don't have to prepare anything. And then yesterday I looked at the topic. It was not just vascular malformation classification. He asked me to talk about pathophysiology and pathophysiology. Obviously, bit of a panic, so I went and read about it. So hope I can convey a little bit more than what I knew. Okay, so let's talk about pathophysiology, classification and pathophysiology of vascular anomalies. So when radiologists look at an image, if you see a bunch of blood vessels, they call it hemangioma. Even now they call it hemangioma, which is very concerning. So we are talking about conditions over around 100 conditions. We all bunch them together into hemangioma. It actually doesn't take us forward. Even the patient's management doesn't go forward if you just say it's hemangioma. So a bunch of people joined together and started this organization called ISWA, which was actually founded in 1992. And then the first classification came in 2018. They basically adapted the idea proposed by Dr. Milligan and Glowacki. And it's actually a living classification. The classification is evolving as we speak. The latest change was a few months ago, last year in 2025. So they basically divided the vascular anomalies into two, vascular tumors and vascular malformations. And a third one is potentially unique vascular anomaly called PUA. So if they don't fit into these two categories, and then they put it under PUA. With vascular tumors, you can have benign ones or potentially malignant or borderline ones, and obviously the malignant ones. I'm not going to read through the list. I'm sure you guys will go back and have a look at it. And the vascular malformation again is divided into fast flow and slow flow. The fast flow can be an isolated AVM or multifocal AVMs, or it is, can be associated with syndromes, what we call syndromic AVMs. The slow flow ones again further divided into capillary malformation, lymphatic, and venous, and combination of all three. So the combination can be depends upon what is in it. So if you look at the letters CLVM on the combined one, basically you'll have capillary component, lymphatic component, venous component as well. So it is quite a simple classification, even though it looks very complicated. It's quite a simple classification if you look into it. But why is it important? It's important because now we have started to recognize some of these are associated with some genetic aberrations. Not all of them, we started to recognize them with some genetic abnormalities. So potentially, we can attack them with medications. So largely, the treatment has been in the past, or even now, the past is surgery. Now we give laser, sclerotherapy, and embolization. Radiologists, we do embolizations and sclerotherapy. Interestingly, the medical treatment started serendipitously. I'm not going to go through the details because I think there's another speaker who will be talking on this. The advances in the genetic research has made us aware of all the mutations in these cases. And these mutations are mutation of just vascular cells, not other cells. So that's why you get this vascular anomaly. So you can actually repurpose a cancer drug to attack this. So that's the reason why we need to know all these classifications. Mainly, there are three pathways, molecular pathways, which are responsible for this. One is RASA mutation. Another one is MAP2K1 and KRAS mutation. Basically, what they do, they control the cell growth, proliferation, and differentiation, and eventually survival of the cell as well. So the outcome of these mutations will be excessive endothelial cell proliferation, migration, tube formation, and vascular remodeling. This is an interesting slide. So this again, I think Dr. Anna will speak on because she's talking on medical management. So there are two, I don't know whether I can point something. So there are two pathways. One is the RAS mutation, another one is a PIK3CA mutation. Slow flow malformation generally will be under PIK3CA mutation, and fast flow will be under the RAS mutation. So you can use the drugs for slow flow. You can use sirolimus. In fact, there was a movement called sirolimus first before, and now we use alpelisib as well in slow flow malformation. For fast flow, we can use thalidomide and even now trametinib. So it makes sense to classify them and know the pathophysiology. So what happens in capillary malformation? The faulty gene is at GNAQ or GNA11, and you get dilatal capillaries, just like in Port-Weinstein and Stewart-Weber syndrome. Venous malformation, again, the gene is in TIE2 or TEC gene, and this is the most common venous anomaly, happens in 50% of the patients. It's a low flow malformation. You would see phleboliths in it. Lymphatic malformation, the gene is in PIK3CA. It could be a macrocytic or microcytic malformation, or you can just have a lymph accumulation. And AV malformation, again, the gene is in RASA1, which is obviously the high flow malformation we talked about, and it's a direct connection without any capillaries in between. So the histopathology will look like this. Capillary malformation, you will have dilated capillaries and endothelial cell hyperplasia. In venous malformation, you will have dilated thin wall veins with reduced pericyte coverage. Lymphatic malformation, you won't have the valve or defective valve, and you will have dilated lymphatic vessels. These vessels are not connected to the normal lymphatics, they are separate. And the AV malformation, as we discussed, is a direct connection, and there is no capillaries in between. So I'm coming to the end of it. There are two other classifications on high flow vascular malformation. One is a Schobinger classification. This is a clinical classification. This is not a radiological classification. Another one is the Aix classification. This is a radiological classification. And there's also a Chodo classification. I think I will leave you there. I think these classifications, I think you can go and read about it. It's probably not relevant to today's talk. Thank you.
Thank you, sir, for the exciting talk.
Thank you so much, sir. So, building on that foundation, we now invite Dr. Prashant Sarda, who will talk about how this patients actually present and how we approach the diagnostic workup in daily practice. Welcome, sir.
Thank you so much for the opportunity. So I am Dr. Prashant Sarda. I work as a professor and head of department in the Department of Interventional Radiology in Dehradun. So we commonly come across these cases a lot, and so I'll just give a brief overview of how we diagnose them and how we go forward with these cases. As already in a very elaborative talk, sir has told about the classifications and everything. So vascular anomalies represent a complex spectrum of congenital vascular disorders, and the problem is many a times the report comes as a hemangioma. So this is not like any report that will come and it will have a word like hemangioma. So hemangioma is like a broader term that has been categorized, and this perspective has to be broken. So historically, all vascular lesions were termed as hemangioma, and this led to the incorrect surgical and medical management. But now the ISAVA classification, as sir has told already, has resolved all the confusions. And that is actually more of a clinical or treatment-based classification, and that actually has to be well documented in all the diagnostic or interventional radiology. So already, basically, sir has told about the ISAVA classification. So what actually clinically or say patient-wise, what comes across is either the patient has a vascular tumor or a vascular malformation. Now tumors, grossly, they are either a hemangioma. So hemangioma can be either an infantile hemangioma, which is the most common entity, or it can be a congenital hemangioma. Congenital hemangioma can be either a rapidly involuting congenital hemangioma or a non-involuting congenital hemangioma, or it can be a partially involuting congenital hemangioma. So these are the very common entities that come across us. And second type of vascular tumors that come commonly are the angiomas, the tufted angiomas or like that. And the second thing is the vascular malformations. And I'm talking about the benign terms. Vascular tumors can be malignant, locally aggressive as well, but we are talking about the benign ones. And vascular malformations. So malformations are usually the permutation and combinations of the artery, vein, or lymph. So basically more of a venous malformations, arteriovenous malformation, or some fistulas, or there is a lymphatic malformations. So these are the classifications which already have been detailed by sir. So I'll not go into the details of all these things. So how the patient present to us? Usually these are the common symptoms. Either the patient comes, usually the most common one are the children, young child or infant, which comes with a swelling, which either is a cosmetically bad swelling or some swelling or some bluish discoloration or capillary malformation is there. Or the patient may come at a later age, in the middle age, like 17, 18, 20 years or 25-year adolescent age or adult age, or sometimes even later. So patient comes with swelling. So this was my thesis also. So I have taken few slides from my thesis showing that swelling is the more with venous malformation, the patient usually comes with either pain, swelling, cosmetic deformity, or maybe phlebectasia or tortuous vessels and hypertrophy. AVMs usually present to us with cosmetic deformity and blush and hypertrophy, swelling, and there is a pulsations and thrill. Hemangiomas are soft tissue lesions. So they have artery, they have vein, and they have soft tissue. So they usually present with swelling, can be cosmetic deformity, and some hypertrophy sometimes, and sometimes they present as pain. Most commonly, patient comes as a pain. If the hemangioma is, say, in the muscles, intramuscular hemangioma, then that muscle function will be disrupted, and then the patient comes to us. So, lymphatic malformations usually come as a swelling. They are not pulsatile. They usually come as swelling or functional hypertrophy. There is hypertrophy, and many times patient comes late with skin changes or dermatosis of extensive variety, or elephantiasis type of thing. Other vascular tumors present as swelling, or they can present in any way. So, what are the common modalities that we have in our hands? Was most common ultrasound, Doppler, contrast enhanced ultrasound in case if we need be on the treatment part. MRI, we go for a dynamic contrast MRI along with the other sequences definitely. CT angiography, many a times patient, even if we do not prescribe CT angiography, many a times patient comes with CT angiography, or sometimes we prescribe CT angiography if we already know the tumor on ultrasound and we just want to know the arterial supply of the tumor. Like say if we are embolizing a hemangioma and we need to know the vascularity, then we can go ahead with the CT angiography or MR angiography contrast or TOF. And DSA obviously with the treatment. So what are the different findings that we look in ultrasound, Doppler, or contrast enhanced ultrasound? Contrast enhanced ultrasound we'll keep aside. It's rarely used and used only when we are treating the patient. But we say about the ultrasound and Doppler. So usually ultrasound means grayscale. So on grayscale, we see soft tissue, cyst, and channels. So either lymphatic malformations are usually cystic, venolymphatics are cystic with the venous component, of course. Hemangiomas usually have a soft tissue component, arteries and veins, and arteriovenous malformations will have the channels, pulsatile vascular channels. And venous malformations will have again channels but not pulsatile. Usually not pulsatile, there may be some arteries at times. Then Doppler effect, of course we put in a Doppler always, and Doppler obviously arteriovenous malformation, the artery flow, there will be arterial flow and venous flow will be arterialized. So we'll have a high PSV venous flow. Hemangiomas, there will be arteries, there will be veins, but the thing is the artery will be normal arterial flow PSVs, and veins will also have a normal non-arterialized flow. So it's more of a soft tissue tumor with a soft tissue. Venous malformation doesn't have an arterial flow, so it will be a simple compressible channels with some flow. When we compress, it will be more evident. Lymphatic channels, definitely macro or microcystic, usually will not have any flow until unless it's a complex one that is a venolymphatic, and usually majority of them are mostly venolymphatic at times. Now, peak arterial flow, definitely, as I already told, this confusion only comes with the hemangioma that is the aggressive or the proliferating phase of the hemangioma, or if it is a non-involuted niche variety of congenital hemangioma. So they have a high vascularity. So sometimes confusion may be there with arteriovenous malformation, that is a high flow vascular malformation hemangioma. We usually go ahead with the peak arterial flow, and AVMs, as I told, always have a more peak arterial flow with mostly 50 to 70 centimeter per second, while hemangiomas usually have a lower flow. Peak venous flow, again the same thing, venous malformation, AVMs always have a arterialized venous flow. So peak venous flow will be high in AVMs, while hemangioma or venous malformations will have a low normal venous flow. Or venous malformations many a times will not show any flow only. They are more like if we compress, we'll see some flow. Vessel density, definitely, if we compare venous malformation, arteriovenous malformation, and hemangiomas, other vascular tumors we can keep aside for the time. So hemangiomas in a rapidly in a proliferating phase. So hemangioma usually, as we know, has 3 phases. Initially, it's a proliferating phase for a year or so. Then it goes into a stationary phase, and then it involuates. So it involuates by around 7 or 10 years. It completely involuates. If at all, it is an infantile basic hemangioma. Otherwise, non-involuting hemangioma will further persist, and partially involuted will again persist. So hemangiomas in a proliferating phase have a high vascular flow, while AVMs will definitely have a high vessel density. A tuft of vessels, we can see the nidus, everything, and venous malformation will not have any arterial flow, of course. So there will be only vascular channels. Phlebolysis is a sign or indication of a slow flow thing. So it is usually present either in hemangiomas or it is present in the venous malformation, not seen in others. So usually, second option we have is the MR angio, that is the dynamic contrast MR angio. These are the different sequences. We go forward with the axial, coronal, sagittal, and contrast enhanced 3D T1 weighted sequences. I'll not go into the sequences, but this dynamic contrast is a very important entity for actually diagnosing between high flow vascular malformations. So it has given us few important points, parameters, like once we give the contrast, MR contrast, and when the vascular lesion starts to show enhancement, that is the arterial enhancement time. Then second is the when it reaches, once the lesion starts brightening up or starts getting the contrast, when it reaches its peak contrast, that is the contrast rise time, and third is the washout. So which one shows the early washout? So if we talk about the maximum enhancement phase, so usually AVMs have an arterial phase enhancement and they show a quick washout. Venous malformations will have a slow rise in enhancement and will continue for long. Hemangioma also persists for longer period. Not longer than venous malformation, but definitely they persist for a longer period. They have a slow rise in enhancement of the lesion and then usually show a very late washout. This if we see in the MR, the gray scale of the MR, like MR sequences, T2 weighted sequences, we'll have venous malformation, which is like we have different things, soft tissue mass, flow voids, fluid level, or nidus. So nidus is a characteristic of arteriovenous malformation. Phlebol is, as I already told, in the slow flow malformation. Fluid level either in the venous malformations or lymphatic malformations. And sometimes there is, in venous malformation, we get hemorrhage or thrombosis, and this creates a fluid level. And soft tissue is actually present either in, mostly in hemangioma, but venous malformation also shows some hypertrophy, so we can find some soft tissue around. But tumor, soft tissue tumor is basically for hemangiomas. So washout, already told, our AVMs definitely show early washout. Feeding vessels, definitely AVM and hemangiomas score over that. Early draining vein is a characteristic feature of AVM and sometimes hemangioma. Not early draining vein is not there in venous malformation or lymphatics. Again, as I told, contrast rise time. So contrast rise time is time which is taken by the enhancement, complete enhancement of the lesion. So it is very high in cases of venous malformation and very early washout in cases of the arteriovenous malformation. Hemangioma show in between depending on the phase of hemangioma, whether it's a proliferating one, involuted one. So these are different MR features that we see across. So I'll quickly go to the cases now. So this is MR sequence, or this is a case. This is the first case which shows a MR sequence. We can see a lesion which is lobulated and soft tissue lesion and with multiple flow voids and enhancement. So this was a case of a hemangioma. Second case, we'll go with the venous malformation. So this was a patient with complex, that is veno-lymphatic malformation. There was venous component as well as lymphatic. So these are the MR sequences which show cystic spaces as well as there are the voids. So this was a veno-lymphatic malformation. This was another case of veno-lymphatic or ectasia, rather veno-lymphatic malformation. So yeah, okay, fine. So we'll just go through. So this was a veno-lymphatic malformation which we ablated. So basically thing is ISAVA classification has to be followed, and that is a very important thing so that we can diagnose or we can characterize the lesions, and this actually affects the management. Thank you.
Thank you so much for the insightful talk, sir. Once the diagnosis is clear, medical management becomes crucial. May I invite Dr. Aparna Annam to share her approach to the medical management of vascular anomalies. Welcome.
Thank you. So it's an honor to be here, actually. So my name is Aparna Annam. I'm from Children's Hospital, Colorado, so from the United States. And we're going to talk about medical management of vascular anomalies. So no disclosures, except for one, and that disclosure is that I myself am an interventional radiologist. And we do a lot of the treatments for these patients. We work in a multidisciplinary team But a lot of our patients, actually, when it comes to the medical management, we have a medical director, and that's Dr. Taizo Nakano. And so, courtesy of him, we actually do work on a lot of these cases and slides together. But he's our medical director of vascular anomalies. He's a hematologist oncologist. So, much of what has already been said, we can briefly go through that, but ISFA classification is a big part of this, because in '96 we looked at all these vascular anomalies as vascular tumors versus vascular malformations. The tumors are dynamic, proliferative, and invasive, and the malformations are static, focal, potentially an error of vascular morphogenesis. And then in 2014, things changed even further, and vascular tumor and vascular malformations, the lines started to blur a little bit more. They took on characters and characteristics of each other. The malformations were more dynamic and tumors were more like malformations. And then in 2018, our genotypes actually were included into the ISFA classification. And that is critical, really, in our medical management, because once you have a gene, you have a target, and you have something that you know you can actually treat, or at least make an attempt to treat if the medication can be tolerated. So in ISFA 2025, this is where we stand now, where we're still looking at all the characteristics of all of these different clinical presentations of vascular tumors and vascular malformations. We define everything by the flow that's actually there, but then we also take into account genetics for this. So we're here today, and this actually is the QR code for the ISFA classification system, if you'd like. Now, we'll talk a little bit first about one of our first patients here. This is an AVM, and it happens to be on his nose. And we'll talk about some of the features of this is that when you look at an AVM, when you look at any malformation, you're going to look at the clinical diagnosis, the radiographic, pathologic, and genetic findings with that. So AVMs themselves, high flow, palpable thrill, they have AV shunting. They can present with some pain and eventually ulceration and hemorrhage. There is a staging system for this. And you can actually see on some of these DSA images just that how the shunting is between the arteries and veins. And you skip that capillary bed. But now what's making all of this move? Why is this actually becoming so proliferative? Well, it happens at a cellular level. And so this is actually, let's look at this as the cell. So we have the outside of the cell membrane, the cytoplasm, and the nucleus. And let's take a closer look at this and look at what's actually being stimulated to grow. So when something's being stimulated to grow, that's vascular angiogenesis, and that's a signal that's telling the AVM to grow. So that probably has more angiogenesis. Now, there's also vascular quiescence, and that actually helps quiet things down. And so these actually, in our bodies, they exist in equilibrium. So we actually all do have this going on all the time. But when one pathway is out of whack and we actually start having more angiogenesis, that's when we can start seeing potentially these AVMs. So if we replace that angiogenesis pathway and we put this in here, this is the RAS-MAPK pathway. And you can actually see that there's a lot of different areas where something could actually, you can have a mutation, something could go wrong, and something could not be regulated properly. And so that's when these diseases actually here are listed in the black. So you have KLA, AVMs, and that's where the diseases are listed. Now, what about the medications that we can use for this? Well, a lot of them came from the oncologic pathways. So oncologists are always looking at how do we control something and not have it proliferate. Well, that's where we have these medications. The ones that we're probably most used to seeing might be trametinib. At least on this slide, we have a few more coming up that we actually use throughout our clinic. But it's a MEK inhibitor, and sometimes that can actually be very helpful. So then we look at the vascular quiescence pathway, and that's telling everything to quiet down. Now, what if something happens along this pathway? Well, this is the SMAD pathway, and this actually is where you might see HHT patients. They probably have deregulation of this pathway. And so sometimes an ALK1 activator can actually help to regulate that as well. So just to finish that off, we have the PIK3CA pathway and the RASA mutation as well. So if you add that in, that's when we start seeing a lot more of our sirolimus, and we see our alpelisib, which is a direct PIK3CA inhibitor. Sirolimus is an mTOR inhibitor. And so putting all of these together, we have wealth of different treatments we can give once we can identify what we need. So let's take a CLOVES patient for a second here, because CLOVES patients are something that we all have seen, and they're very unique because they do have a genetic basis for this. It's not necessarily a germline mutation, it's a somatic mutation with mosaicism. So that's why when you see these patients, there's many different areas of tissue that's actually affected with overgrowth and varying presentations. So what you have on here are some images of the fatty overgrowth. You'll see those fingers actually look a lot bigger than the other ones. This is all an overgrowth kind of syndrome. The legs as well and the hands. And so that's your clinical presentation, is when you see these kinds of deformities. But then you also have the radiologic findings. Looking at the MR scans, you see the facial and neurologic involvement with that. This patient actually did have, at one point, a hemispherectomy and VP shunt placement. So all of this, kind of clinically, we look at this and we say this probably is going to be CLOVES disease. But one of the things we need to do is, it's nice to confirm this and actually have your gene. So these all fall onto the PIK3CA-related overgrowth spectrum, or PROS as we call it. And as I was saying, this is a somatic mutation in this case that then has a mosaic kind of presentation. So it's a post-zygotic acquired mutation, but then the phenotype expresses differently throughout the body. And so that's why you have all different kinds of varying presentations. So the approach to genetic testing for these is really, you have to detect down to the lowest level mosaic variants. You need to get affected tissue. So not just any tissue, but just affected tissue. And then do you want to detect that a variant allele frequency? And that can be as low as 5% or even 1%. So you really do have to look for this. And then consider reevaluation of your sample if you actually don't get an answer. Your sample tissue may not have been the right kind of tissue, but if you know that you're looking at a CLOVES patient, you really do want to find the right tissue for that. This genetic testing has really taken off, and now cell-free DNA is also in the mix. We don't do that at our institution, but other places do. So these are more areas that we actually do want to consider for getting our answer. So again, this is what your whole presentation is going to look like. This is what the pathways are that we know of. And the other patient then here that we'll talk about is going to be this kind of picture as well. I think a lot of you have seen this. This is what we see on the leg here is a capillary stain. That's going to be our clinical picture, but what else do we have? We have in these patients, they have a large embryonic vein. We may or may not see much of a deep venous system, extensive slow flow malformations throughout the extremity. And when we see a picture like that, we think of Klippel-Trenaunay. And that's another, again, that mutation, but now you're looking at the marginal vein that is really not functioning well. So when you have a marginal vein that's not functioning well, you can actually lead to thrombosis. So this is just a chart of what Virchow's triad is, where you have stasis of blood flow, so you get this elevated D-dimer, a consumptive coagulopathy, and malformed endothelium. So it's not really a normal vein. You're not conducting blood properly through that. That is an actual setup for having a deep vein thrombus, or a large thrombus form in that. And then that itself, when these small connections into the deep venous system are there, they actually can develop a pulmonary embolism. So what we do see here in a lot of these patients that have these abnormal veins, you might see a localized intravascular coagulopathy. That just means that all of those clotting factors are going to that localized area. So if you were to have a procedure done in another part of your body, then it's potential you can go into DIC. So complications of this are DVT, embolic PE, venous insufficiency, orthostatic hypotension, periprocedural hemorrhage, and pain. And so in order to actually manage this in our patients before we actually treat them, we actually do put them on anticoagulation prior to the procedure to really calm down the coagulation cascade. And that actually usually does help them quite a bit. And again, I'm just going to leave you with this picture here. This is our pathway of vascular quiescence and vascular angiogenesis, and the pathways that have all been mentioned here. And thank you.
Thank you so much for the talk. Next, we move on to most commonly encountered entities. I invite Dr. Abhay Srinivasan to speak on hemangiomas and other vascular interventions. Welcome, sir.
Thank you. So and my sincere appreciation for the opportunity to present on this talk. I will be going through these slides pretty fast. My apologies, but happy to share slides as needed. So objectives, very quickly, as esteemed speakers have gone over, I'm going to very quickly go through this with classification and move on to discussing the relevant vascular tumors. To reiterate, two big categories for this with classification. One is vascular tumors, others vascular malformations. What is the difference between the two? Very simply, vascular tumors have a stroma in addition to replete vasculature. It's going to be too many vessels in compared to normal tumors, but there's also going to be a solid substance to the lesion, as opposed to malformations which do not. We should also keep in mind that how do you make this diagnosis? Well, there's a physical exam, but also ultrasound and MRI are complementary. You really have to look at these lesions with two modalities, if at all possible. It really will help to hone in on the diagnosis. So regarding tumors, this is a whole list of tumors in the new classification, the 2025 revision of the ISSWA classification. Not going to cover everything, obviously, and a lot of these, in fact, are somewhat controversial in my mind, but this is the QR code. There's a QR code again for your benefit. But the way these tumors are divided as benign, borderline, and malignant, as Dr. Sarda had spoken about. We can also divide it into fast flow and slow flow, as the classification does, and these are the entities I'll be covering in this talk. Hemangioma, number one, the most common vascular tumor of children is infantile hemangioma. Lots of arterial vessels. This is a high flow lesion. It can be focal, it can be multifocal, it could be diffuse. Sometimes it's superficial, sometimes deep, and often they're in the head and neck. And when it's near the airway, for example, it can be in a critical location. Key aspects here, number one is GLUT1 positivity. If you ever biopsy this, it will stain positive for this glucose transporter called GLUT1. That's a key thing to know. And then one thing about infantile hemangiomas, they present after birth. So you ask the parents, when did you see it? It should be after birth, and it should involute slowly over the first decade, as you see on the pictures down below. Congenital hemangioma, three types, rapidly involuting, non-involuting, partially involuting. Dr. Sarda covered this in his talk. GLUT1 negative, remember that, so it does not stain for this glucose transporter, and then mutations are GNAQ and GNA11, similar to capillary malformations, but of course these are tumors and not malformations. So this is the thing to look for. Hemangioma in the red present at birth and moves on, involutes slowly over the first decade of life. You have non-involuting, partially involuting congenital hemangiomas that present in utero, but sometimes involute, sometimes they don't involute. But you have to keep that in mind. What do they look like when you see these patients? If they're superficial, they look like these big red bulges. If the child has dark skin, sometimes it's not so red, but it can, depending on depth, have varying appearances. If you see a halo like you see in the lower two pictures, sometimes they call that as a sign of congenital hemangiomas. Just keep that in mind. I don't know how specific that appearance is, but that's one thing to keep in mind. How does these look on imaging? One, they have this lobulated margin, very well-defined lesion. Color Doppler, lots of vessels going through it. Spectral Doppler, you will see low resistance arterial flow. That's important. And then this is what it looks like in MRI. Similar appearance you have on the T2 imaging. Lobulated margins have some flow voids to indicate that this is a high flow lesion. It enhances diffusely on the post-contrast images. Very vascular. Move on to the locally aggressive category. Camptosiform hemangioendothelioma is the index tumor here. It looks very similar to tufted angioma. Key points here, infiltrative lesion. On imaging, you will see it infiltrate. It's within the muscle. A majority of these will have Kaczmarek phenomenon, which is a consumptive coagulopathy with elevated D-dimer, low platelets, and can produce a lot of morbidity. And then large KHE can produce high output heart failure. Here's a cross-section of what these things look like on MRI. Intramuscular lesion, appreciate the infiltrative margins. It's not at all well-defined. It just insinuates through the tissues here. Involves both muscle and soft tissue often. Here, this is in the subscapularis muscle, and this is all within the triceps muscle. So intramuscular lesion with infiltrative margins here, and here's one more. Hemangioma and KHEs, what do we do to treat? For hemangiomas, it's usually nothing. But if it's symptomatic, it's medical management, often with a beta blocker or some other more powerful medications if it's really big. For KHE, the common medication use is sirolimus, but IR is involved sometimes when there's high output heart failure predominantly, or if it's in a critical structure, or if there causes some impediment otherwise. So IR can be involved to manage these lesions. So this is to indicate sometimes no treatment is needed. You have a child with hemangiomas throughout the liver at birth. So this is a congenital hemangioma. It involutes about 11 months later. So this is RICH, rapidly involuting congenital hemangioma. Another case here where IR was involved. This is an infantile hemangioma, big tumor that simply was too obtrusive to leave alone. It did not involute in time. This is a 2-year-old. Ended up embolizing this lesion for pre-op, and then the patient went for bloodless surgery shortly after with a good result. KHE, very big infiltrative lesion in this newborn, had Kasbach-Merritt, and also had high output heart failure. This, apologize, I used very little contrast for this, so I couldn't get you good images, but this is pre and post. Embolization was done mainly to stave off high output heart failure in this kid, and he did very well, moved on to sirolimus, and then looked, this is a 1-year picture, doing much better. Moving on, in the aggressive benign category, intramuscular vascular anomaly, it was classified as a vascular anomaly in the 2025 iteration, but I think it's a tumor, so I'm putting it in the tumor section. Treatment options here is excision, embolization, cryo, MAP2 kinase mutation. It's throughout the muscle and has high flow through it. As you can see, this is one forearm lesion where you can see how much AV shunting goes through here. It's a tumor, high flow tumor, but all within the muscle in an older patient. This was for pre-op embolization that I treated in this case. This is a case for my partner, similar lesion in the trunk. Intramuscular vascular anomaly was treated with cryoablation after it didn't respond to embolization. Good result with cryoablation here. Next, we move on to P10 hamartoma of the soft tissues. This is a vascular tumor seen in patients with P10 hamartoma syndrome. Can be either fast flow or slow flow. If it's fast flow, it ends up being quite aggressive and can be very painful and lead to serious debilitation. Options, again, embolization, cryoablation, sirolimus as well. This is a slow flow lesion from one of my patients. Again, asymptomatic. I have not done anything about this. This is a high flow lesion infiltrating the quadriceps muscle. Ends up being very painful. Patient has undergone embolization. Patient has undergone cryoablation. This has been a very hard tumor to control, but just to show you the fast flow and slow flow versions of post. Fibroadipose vascular anomaly, painful tumor within the muscle, predominantly veins. It's difficult to distinguish on pathology from the slow flow version of FOST, but responds poorly to sclerotherapy. Treatments for us would be cryoablation, sometimes sirolimus and excision as well. This is what it looks like on the T1. You'll have little fat signal on the T1, T2 fat set. We have vessels and the fat will suppress out. And finally on the ultrasound, you'll see echogenic stuff with lots of vessels there. I treated this first with sclerotherapy. This is the first time we did cryo in our hospital many years ago, but the patient responded to cryoablation. This, I'm not going to belabor this. Dr. Anam spoke very eloquently about this. 2 main pathways, MAP kinase pathway and then the PI3K mTOR pathway. You have multiple agents here that are available to treat these tumors.
Sir, a gentle reminder, you
Thank
have
you.
2 minutes to conclude.
Thank you. And again, 3 main categories of medicines: MEK inhibitor, alpelisib, and your direct P3C inhibitor, which is alpelisib, and then sirolimus, which is your mTOR inhibitor. All of these can be used. Angiosarcoma, bad news tumor, right? It is a very dangerous tumor, very nonspecific appearance, only it's full of vessels. This is an angiosarcoma of the heel found on biopsy by the orthopedic surgeon, lots of vessels going through it. This thing bled unexpectedly. And this is a 2-year-old with a big liver mass. Well, how do you tell this from hepatoblastoma, for example? Well, too many vessels and looks kind of ugly. The course is very, very bad, very malignant course. You have to biopsy this to get a diagnosis here. And finally, EHE is a last tumor in the malignant category aside from angiosarcoma. Is a very slow-growing, as opposed to angiosarcoma, indolent tumor. It has mets to the lungs and liver, but the patient actually does pretty well despite the fact that there are mets to multiple organs. This is one case here coming up. Intramuscular lesion looks like, for example, the intramuscular fast flow anomaly, but on biopsy, this was an epithelioid hemangioendothelioma. this multiple small lung mets. These lesions respond well to irreversible electroporation, just to keep that in mind. So summary, ISPA classification, tumors versus malformation is a big division. Tumors have stroma, vascular malformations don't. Big divisions are benign, borderline, and malignant. We covered hemangioma as your benign, in your benign category, infantile and congenital. Fibrous adverse vascular anomaly, also benign. Borderline is KHE, intramuscular fascicular anomaly, and also the two P10 hamartoma soft tissues. Finally, malignant is angiosarcoma and EHE, epithelial hemangioendothelioma. Features and imaging are intuitive. Please look at these with MRI and ultrasound. Of course, some of these will need biopsy. And then IR is well suited. Main procedures here are embolization and cryoablation. And there's increasing overlap with and role of oncology for pathogenesis, elucidation, and for management. So thank you. Again, I'm sorry it was a very fast presentation. Happy to share slides. Thank you.
Thank you so much, sir. From tumors, we move on to malformations. May I invite Dr. Murthy Chennapragada to discuss practical aspects of managing venous malformation. Welcome, sir.
Thank you so much. And good morning, everyone, and thanks for having me. It's my absolute pleasure, and it's so nice to be back here amongst friends and family. It's like family reunion. Every year I come here. So thank you so much to the organizers for having me, Satish and the organizing committee. At the end of this session, you all are going to walk out of this room being experts in vascular malformations and anomalies. Not really, thanks. I'm sorry to tell you that. We're going to try and I'm going to try and make it a bit simple, try and sort of focus on the main points to take away. These are my affiliations. I have no financial disclosures yet. That's my goal for retirement. If you don't take anything away from these sessions, one slide that you want to carry with you today is this. Please remember, not all vascular anomalies are hemangiomas or vice versa. Not all hemangiomas are vascular anomalies. Vascular malformation is not synonymous with AVM. A lot of our diagnostic colleagues, a lot of our medical colleagues use these interchangeably. You may ask, what's in a name? Quoting Shakespeare, a rose is a rose that smells as good. But if you did not call me Murthy and you Anil, there would be no differentiation. And if you did not use the right name, you cannot use this right treatment, as basic as that. So it is very, very important that we use the right name, right nomenclature, and that's where ISPA classification is really utmost important. We've gone through the iterations of ISPA classification, so I'm not going to reiterate, but remember that ISPA classification is a very scientific way of classifying this based on the anatomical, embryological, biological, and now genetic basis for classification. So this is going to be a dynamic classification. As we know more, this is going to change. So the famous adage about the more we know, less we know. The latest classification, the 2025 classification, this is a very simplified version of it, and we're going to talk about venous malformations in particular, and I'm going to simplify that into just the isolated sort of sporadic venous malformations. So what are venous malformations? Think varicosities. Veins which are not formed well become little spaces. So these are ill-formed because of scrambled coding. So your genetic coding gets scrambled, so veins, channels become spaces. If you remember that, it's easy to understand what are venous malformations. So you can, based on the way they behave, you can call them slow flow malformations because there is slow flow, sometimes low flow, or sometimes no flow even. The veins are dysplastic, endothelium is malformed, so therefore venous dysplasia is part of it. And so therefore there is abnormal morphology, abnormal location, because they can be formed anywhere that veins can be formed, which is basically entire body, and they are abnormally numerous because the coding is scrambled. A lot of these bear their origin to somatic mutations. More than 50% are related to TEC gene. So basically that's the relevance in terms of looking at drug therapies, targeted drug therapies. A good majority of them are also related to PIK3CA pathway, which you've now been familiar with over the last 3 or 4 talks. So clinically, they present quite variably. They are already present, so they are congenital, but the true incidence is never known because they can present at any point in time in your lifetime. So they can be congenital, or they can be found in a well-grown adult who's been having some symptoms all through their life. They typically soft, compressible lumps. If they're superficial, they can cause bluish discoloration. Sometimes they can be confused with hemangiomas, which have purple discoloration in a young child, especially a fair-skinned child, or even a dark-skinned child. They often increase with exertion. Your parents may complain that, oh, this swelling becomes really big, doc, when the kid is running around. That's because the blood flow has increased, so venous ectasia, venous filling has occurred. These are isolated, sporadic ones. But then you also have the extensive ones, which may present with disfiguration, swelling, limb malformation involving the entire limb or perhaps even entire body. So there are large dysplastic veins. These often present with pain and swelling, and the pain may be related to either microthrombi, microinflammation within the tissues, or extensive inflammation, and leading to what was earlier described by Aparna, localized intravascular coagulopathy. And the treatment really does sort of is focused on minimizing and mitigating the symptoms arising thereof. Now, big question, what do you do to image these, and when do you need to image them? Do you need to image them all? Not necessarily. Well, oftentimes you may not really need a lot of imaging. If you do have to, ultrasound is the best imaging modality. Very easy, very cheap, very accessible. What do you find on ultrasound? On ultrasound, you often see well-defined spaces. They are sort of compressible swellings. Most importantly, no intervening matrix. Remember what we talked about. Tumors have intervening matrix. Malformations do not have intervening matrix. They're compressible, and they may not have any velocity, any flow. So they are either no flow lesions or slow flow lesions. Sometimes you may have to actually give a good compression for Doppler to pick up some of these forms. One caveat to remember: if your diagnostic colleague has said, oh, there are arterial flows in these, and therefore it's an AVM, be very careful, be very wary of it, because you will find arteries in any tissue, particularly if it is in a muscular venous malformation, you will find arteries. There are intermuscular arteries. The key bit is that these will show high resistance waveforms, because these are not your typical AVMs which show low resistance waveforms. Is there any relevance in looking at RI values, velocities? Perhaps not. We don't use that in a regular sense. We don't really rely on those parameters. Some people do, some diagnostic colleagues do, but really it is very simple. MRI, when do you use them? MRI, I use it when I need to know the venous drainage. What is the draining veins? Because that's relevant for my treatment. If there's extensive involvement, I'd like to know what all structures are involved. If there's joint involvement, I'd like to know what is synovial involvement. Is there articular involvement? Or in specific locations such as orbits, head and neck, is there intracranial communication? These are the situations when you need MRI. Again, you don't need to do a 1 hour long MRI study. You don't need to do 20 different MRI sequences. All you need is one T1 weighted, one fat saturated sequence, a T2 weighted, a T2 fat sat stir. I often don't even do a contrast if it is just this particular question that I'm answering. Yes, contrast study is useful for venous drainage and mapping out your venous vascular sort of features. Phleboliths are very well seen on MRI. That's an added advantage. These are the typical appearances. Sometimes you actually see fluid levels in these spaces. Don't mistake these for lymphatic malformations, because they can mimic lymphatic malformations, particularly with fluid levels. Venography is useful to classify. Pugh classification is not very commonly used. We don't use them on a regular basis, but it is useful to know what venous drainage and how angiographically they look like. The type 1 and 2 are easier to treat. Type 3 and 4 are more difficult to treat. Now, mixed malformations, we talked about it, but in reality, in clinical practice, what are these? These are all lumped together as one, and very often, more often than not, these are perhaps part of the PIK3CA-related overgrowth spectrum, PROS. And although it might sound like you're lumping them all together, but that's essentially what it is, because that's what directs your management. Ultimately, what are you trying to do? You're trying to treat this patient. Well, when to treat and how? Most important thing is to determine the need for treatment. Not every malformation needs to be treated. Establish your goals of therapy, talk to the parents, and clearly explain what is your goal of treatment. You're not going to ameliorate and completely make the malformation disappear in the majority of situations. You need to manage the expectations. what are our options? We have sclerotherapy, surgical resection, medical management. I'm not going to go into much detail in these. I'm going to really quickly sort of superficial in touching upon these three modalities. Sclerotherapy, the aim is to obliterate these anomalous vascular spaces so you reduce the size of the malformation. This is an example of a child who had a big knee swelling, was in fact diagnosed as a sarcoma before they reached us, and we diagnosed this as a venous malformation, ultrasound guided injection. That ultrasound shows the bright echoes, which is the foam that has gone into the malformation. And after two sessions, the MRI shows the shrinkage of the malformation itself. There are various sclerosant agents available. I'm going to take one more minute if that's okay. The technique of sclerotherapy is, again, the art of sclerotherapy. Basis is a science, but it is an art. As with any procedure, you devise your own technique of how you do it. This is just my recipe, doesn't necessarily mean this is the recipe. We do it under GA most often. We use 20 or 21 gauge needles to access the malformation. I perform a venography almost regularly. Sometimes if it's a very localized malformation, I use tumescent anesthesia, basically dilute lidocaine around the capsule of the malformation, so you shrink the malformation. Advantage is that you have local anesthesia, but also you reduce the amount of fibrovein or the sclerosant agent that you require. You get better sort of surface endothelial apposition and contact of the sclerosant agent. II control to use, make sure that you've got adequate filling of the malformation. In terms of the agents, most common agent is fibrovein. One more minute if that's okay, please. STS is the most common agent, Tessari technique, which we all are familiar. Ethanol, not very commonly used. I don't like using ethanol because of really extreme sort of denudation. Bleomycin is the other agent. Post-op care is really important. All of our patients go on to compression dressing after the sclerotherapy. We review them in 3 months, imaging in 6 months, and repeat sclerotherapy if is required. Again, I'll re-emphasize goal of treatment is important and managing expectations is as much. BEST, which is the bleomycin electrosclerotherapy, which is a new kid on the block, basically uses electrical impulses to the tissue, improves the tissue permeability to bleomycin, therefore reduced dosage is required. And I'm not going to go through this in detail, but I'll leave you with a simplified version of this. 2 pathways, PIC pathway and the RAS pathway. Drug therapy is directed to each of these. There are new Tie2 inhibitors called, that are available as well. So as the drug therapies improve, I think the way we treat this will change. We don't do biopsy a lot of these malformations, but I'm tending to do more of the biopsies because that is helping me, pick the drug therapies more accurately. Apologize for overshooting the time, and please note that SPIR meeting this year is in Scotland. Head out to the website to register. Thank you.
Thank you so much, sir. Due to unforeseen circumstances, Dr. Shikhar Garg is unable to join us for his talk today. So before moving on to the panel discussion, we'll talk about 2 minutes for any questions and comments from the audience.
So are there any questions from the audience?
Regarding the venous malformation on venography based sclerotherapy, so how to tackle when we see that there is a classification that it is going to the smaller veins, ectatic veins, so how to treat it means stopping the sclerosant to remain in the sac.
Yeah, so first of all, the venography, I just mentioned it most because of classification purposes. It is largely academic, and I'm sure most of my colleagues will agree that we don't use that classification very often. So one of the techniques that is often used is outflow compression, either tourniquet compression or even just physically manual compression if you see a closed vein. What I have used, the other small techniques that I've used is when you see a venous sac opening into a draining vein, a normal vein, if you identify that neck of the normal vein connecting with the venous sac, I try to sort of target that spot and inject it with a bit of gel foam soaked in Fibrovane. It acts as a stasis, acts as somewhat of an outflow control. If it's a large space, then I've also used balloons to occlude the outflow tract in large venous spaces. So outflow compression and outflow control is a good technique to try and prevent your sclerosant to drain off.
You can also get your
So, means you're directly puncturing where it is draining into the fiber
Correct.
vein there,
and
just
then
to
putting a
stop
little
it,
bit of
and
so
glue
you
or something,
and then
to
come
stop
back
it.
and treat the main.
But maybe a word of caution, because some of these very large veins, especially if there's a large outflow from the malformation, I've found a few kids going a little bit breathless after I've injected they could actually form some thoughts and control.
Yes, so that's the reason why you kind of get the outflow control, right? You're not going to inject the normal vein, you're actually injecting the
One question.
abnormal vein that's draining out.
Yeah.
So my protocol is usually inject dwelling time, and I always use a venting technique, which I've not been able to sort of describe it. So you at least have 2 needle accesses, and basically I use the same venting technique. I'm pretty sure everyone uses that for lymphatics as well. Any slow flow malformations, you use a venting technique so that your dwelling time is minimized. Basically, if you're using STS, you're depending on the endothelial contact of the STS, and you don't really need a long dwelling. Doxy can be left in for long dwelling. It probably doesn't hurt unless in a neonate when they can get systemic absorption and hypoglycemia. But STS, you don't want any systemic absorption, so you want to leave it for dwelling. So we usually use about 10 to 12 minutes of dwelling time and then drain it out. So don't over-inject the space so that there is no extravasation from the space itself. And that's where venography helps as well, because you're actually mapping out so that your needle access is not causing any extravasation, any tissue extravasation, particularly in muscles and so on. Yeah.
Just one question. When to, might have missed possibly, what are the indications of genetic studies in these, and when to consider medical treatment?
Okay, so this is something that I was going to mention. Perhaps Aparna can jump in as well. But we were not doing so many biopsies. Now we're doing more biopsies, because my indication has always been recurrent malformation, non-responding recalcitrant malformation, and then to look for genetics. That's because you didn't have a lot of options before. Now you have a lot more options. What's that neotype 2 inhibitor, Ribastinib, is also available. So there's more options. So my indication at this point in time is, if I have a malformation that is recurrent or recalcitrant, not responding to treatment, or if I think that there is more extensive involvement, benefit in sirolimus or one of the other drugs, alpelisib, that's when I'm doing biopsies. Aparna, is that your practice as well?
I would love to have biopsy in everyone.
Yeah.
But I know that's not feasible, but exactly the same things that you do, the same criteria I would use. Anything that's not responding or is very large, or I suspect that there's going to be something more complicated, I would actually opt for biopsy. If there ever is in doubt, I think you're better off getting a piece of tissue and trying to get histology and genetics.
The problem is also the genetic panel being available.
Make it cost sensitive.
Summarize, I would say, if the patient is not responding or there is extensive involvement, go for genetic study.
At this point in time.
So, Aparna, what's your view on liquid biopsy, taking blood off from high flow AVMs? Aparna, what's your view on liquid biopsy, taking blood from the high flow AVM site? I tried it, doesn't work.
It does. we just published, one of my colleagues has just published, but 20 cases, these are AVMs. We did venous drainage, sort of venous sampling, and we were able to, there was one kid just mind-boggling, has a spinal AVM, was paraplegia. We did this, found, it was, and basically ended up being eligible for Trametinib. 3 months, he's walking about, and it's just, mind-boggling. I think Trametinib is going to make a huge difference to AVM treatment. So going back, liquid biopsy, the extraction is great.
So where do you take it? From the arterial side or from the venous
From the
side?
venous side.
Venous side. Okay, so I have a Parks River by, we tried, it's a massive malformation. We couldn't get anything from the venous side. I tried the arterial side, nothing came out.
I can put you in touch with my colleague, so
Yeah.
he might give you some.
China, there was at the SBIR, they, a group from China actually published this abstract. They showed that the rate of positive result is greater if you're at the nidus, the closer you are to the nidus. So if you sample the blood there.
Right, I think they pointed that out as well, that they're doing more of that. We actually don't do that from venous blood. We try to go directly for the lesion, for either percutaneous tissue. Sometimes it's surgical biopsy if we don't have enough tissue. But I think that's the next step to go, that and cell-free DNA.
Since we are running out of time, to wrap the session, we have a very practical and relevant panel discussion. May I invite Dr. Prashant Sadda, Dr. Murthy Channapragada, Dr. Vinod Malkar, and Dr. Satish Ramamurthy to share their experience on setting up a vascular malformation clinic in India.
Dr. Vinod is not here,
Okay, sir.
so we'll be missing him. Yeah, we can put some chairs here, but anyone who's running a vascular malformation service in India will be a welcome addition, because this is not a very formal talk. It's just addressing some challenges about setting up a vascular malformation clinic here. So I'm sure we are all feeling very low about how little we know about vascular anomalies after listening to all these luminaries. So it is a wake-up call to say how much more is there than what we see, and it is just not injecting some STS and bleomycin and say that we are running a service. So running up a service as a whole is a multidisciplinary approach, and I'm sure you all agree to it. Chandramohan, can you also join? Because, yeah. Luke, yeah, you can join Luke. Because in Asia, it's all, we are all facing the same challenges. So I've just got few questions that generally to think about, I'll read out the questions. I know it's not projecting there. The first question is, do you all run a face-to-face or a virtual MDT? Because in India, running a face-to-face MDT is a big challenge. People all they have their own practice. They will not come and sit in one place. So I'm sure it is, how about your own practices? Do you all have a weekly meeting or something like that?
If you want me to start with, just be aware that once I have my mic in my hand, it doesn't go away. So our vascular malformation service has been around for some time. It's just grown. In different ways. The way we are set up initially was primarily run by IR. So I and my colleague more than I did, ran it, and we had a face-to-face clinic. We were probably one of the first ones to have an IR clinic in our country, in Australia. That grew to a point where, at this point in time, we do have a face-to-face MDT, which is a hybrid sort of thing now because of post-COVID. That has one good thing that has happened is that a lot of Teams meetings and Zoom meetings can occur. So the MDTs are hybrid meetings, but we do have a vascular birthmark grand round clinic where we get dermatologists, plastic surgeon, IRs, medical oncologists. All 4 teams, we have a whole day of clinic where we all are seeing all the patients, going back and then going through the imaging and management decisions one after the other. And so this is usually a quarterly one, which has really been beneficial because then you have everybody under the same roof. We're able to make management decisions.
What kind of cases do you get to these? Like, for example, if you have, I'll give you an example. Say you have someone with a very simple VM, and you know very clearly it is a very localized VM, sclerotherapy will help. Do you take this to the MDT? Or do you selectively take complex cases where you need other inputs?
Yeah, so not necessarily. So they depends on the referral pathways. So each of these teams have different referral pathways. So surgeons refer some to us, dermatologists refer some to us. Some of them circumvent us and then go straight to oncology, and they will refer them back to us. So it's a little bit of a maze. It's not quite a very straightforward pathway, not linear, but it's a bit of a circuitous route. Once each of us have determined that, hey, look, this is a more extensive venous malformation, I perhaps I'm not going to get a lot of control. This patient might benefit from sirolimus. And if I think that way, I will take them to the MDT. Or if I think that this patient has a capillary malformation, has also CM-AVM, I could look at the AVM component. Perhaps the CM component could be helped by the dermatologist. Is there a role for laser? I will take them back to the MDT.
So this is for Prashant also. Yeah. See, in India, we have this difficulty getting various specialities to kind of accept that someone else is going to take the lead. Yeah. Like the problem we face is the plastic surgeon thinks they are the boss. The ENT surgeons think they are the boss, because if it's anywhere around the ENT, they say plastic surgeons have no business doing it. So it is a problem. So if the patient comes to us, do we refer to the plastic surgeons where there is no role for plastic surgery? It is going to be a simple sclerotherapy.
Sir, actually, like Sir told, it's a maze. Like most of the patients come through some pathway. Like plastic surgeons are the most common to refer us. Yeah. Then pediatricians. So do you think
they refer a lot of cases to you, or if they get 100 cases, they probably refer 3 or 4 to you?
They refer a lot, because now it's like it has become a common dictum, like at least have a IR review before we plan anything. Okay. Because they must have burned their hands and everything. So it's like a routine practice in our medical college, our hospital.
For slow flows also? For venous malformation?
For venous malformation, AVMs, hemangiomas. Even hemangiomas, many a times they refer whether you need any preoperative embolizations or not. And if it is not needed, we just refer it back. So many a time it is more of a virtual phone, over the phone meeting, because they are also packed up with their OPDs. Sometimes we have this multidisciplinary meet. For some cases, we have a defined thing that patient will get under us once we are done with the procedure, or we'll send back if some part of there is needed, or else they can do a hybrid with us in the same. We have got a hybrid cath.
Yes, because you are in an academic setup, that is possible. Yeah. But in a private setup, that is very, very, very difficult. Because what happens in a private setup is they do not want to they don't want to share. They see it as a problem that they can solve everything. So it is very difficult to be so
try to keep on them.
Like this. Sometimes what happens is they will refer, like the hemangioma case you said. Hemangiomas don't need excision, right? Most hemangiomas don't need excision, but they will refer to you for pre-op embolization because they want to excise.
They want to excise.
Okay, now you are in a dilemma, right? Are you going to embolize because you know that this is not the right treatment? If you tell them that this is not the right treatment, they are not going to be happy, and they will not even refer a VM to you. So it's a catch-22. These kind of. So that is why what I have started doing is I have started referring all cases to the plastic surgeons also, because luckily we have a plastic surgeon who is kind of very altruistic and sees what is, and especially this being pediatric age group, it's a little bit better than the adult age group. So they will look at all that, and they don't want to deal with the parents who may ask them 100 of questions. So if they come to me directly, I'll tell you that this most likely will not need surgery. However, can you go and see the plastic surgeon? And then I'll immediately call the plastic surgeon and say, I'm sending a patient. I don't think surgery is needed, but may need at a later point, and can you see? So that kind of, these are all just jugaad or, under the table dealings and you scratch my back kind of thing. But unfortunately, we got to do all these things. But that has seemed to have worked for us. We do get crossover. Yes, Mohan?
I think you need to increase awareness within the patients. So you need to have, a lot of people are now social media savvy. So post your successes in social media, let people know.
Yeah, there's a big problem with us because the medical council has come down hard on what we can and what we cannot post in. Even pre and post images you cannot post in social media.
I see.
You cannot have patients' testimonials for a particular procedure.
Right.
So all these you can only talk about a procedure explaining the pros and cons, but you cannot have a patient come in and give a testimonial. Right. Do you know all that in India? Now the newer regulations are those. Yeah. Patient testimonial is not acceptable, and there is nothing that works like patient testimonial. I can say a lot about sclerotherapy for venous malformations. Unless you show a pre and post image, patients are not, even when the patients come to a clinic, we show them pre and post images. Just to reassure them, see, don't worry about it, we had a patient like this, we did this 6 months later, immediately after the sclerotherapy is going to swell up, see it swell up like this, like the images that Luke was showing. But then if you show them to them, they are able to accept that a little bit better, but you can't post it on social media.
So You're not allowed to have a
No, no, no.
YouTube
We are
channel
not allowed to
yourself.
post all these things. You can have a social media presence
Uh-huh.
where you can say sclerotherapy is good for venous malformation. That's it.
You're not allowed to show any pictures.
You can show, you have to hide all the information, you have to take the consent.
You have to take consent from the patients, and even if you take consent from the patients, not allowed. It's not allowed, not allowed, not allowed, not allowed.
Testimonial is not allowed.
We are
No, no,
doing,
patient
but
consent and pictures are also not allowed. Before and after is not allowed.
we are doing, but in India, but actually not allowed. Like anytime things can turn against you.
Yeah. So especially in private practice, it becomes very difficult because there are always people out with the daggers.
Okay,
So
Look what,
Yes, medical ethics on it is not allowed.
look
It is
what.
right from the beginning, it is not allowed. There is no change in laws.
Yeah,
Okay.
it can any
yeah,
day.
exactly. So now they've kind of come down more hard on that. So the
Yeah,
other
ma'am.
question is like
may
what
I,
we-
may I
yeah, go on.
suggest that identify a few more influential patients. So amongst your patients, especially in your private hospital, you have the more well-heeled patients who have a big circle of friends who have deep pockets, who can then start a society. And I think once you start a society that's run by grateful patients, so your subsequent patients, you shun them to this this support group.
We are trying
as
to
a
do
peer
that.
support group.
Yeah, we are trying to
Then
do
they-
patient support group. And then
Yeah.
the patient support groups can
They
go
can
on and put
say
their
whatever they
pictures.
want
We
to
are
say.
not allowed to do that. We just started doing that.
Then you can be a medical advisor to them.
Yeah.
And
So other issues we face is like what we've been talking about all day in the ISFA classification. Most people don't. We as IRs know about ISFA classification, but most general radiologists, pathologists, even your pathology biopsy report will come back as hemangioma. And now it is very, very difficult to convince the patient otherwise. Because the patient goes and asks ChatGPT, what do I do for hemangioma? And they say, beta blockers. So they'll come back and say, why are you not starting on beta blockers? So we do face those often. So educating everybody is very difficult. The problem is once you educate, they may leave the post and go. And then you have now lost them. So those are all the other challenges. What about turf issues? Prashant, you are facing any turf issues from vascular surgeons who want to inject and all these things? Because we have a big, big problem in South.
So there are always gray areas, like whoever gets the patient. Now, many a times patient comes from outside, they come searching for us. Now the patient has also, like because of like everywhere intervention radiology is now growing up, so patient also knows about the intervention radiology. So they search it, they Google it, and they at least, and patient always have a habit of taking opinions.
Yeah.
It's not like they are
Yeah.
my patient or anybody's patient. They will come to me, they will go to plastic surgeon also, they will go to a vascular surgeon also. They will have the opinions,
Yeah.
and whichever satisfies them is the one whom they are going to
The
get.
biggest problem is if you tell them this will need 4 or 5 different sittings,
So
they don't like it. They just want one-stop solution. So the plastic surgeon will say, I'll operate and it'll be gone. So they just want one-stop
scars.
solution.
They don't want
Yeah.
scars nowadays.
Look, I think vascular anomalies are difficult. They're not simple, straightforward. That's right. And I think the only way you can provide a meaningful service is if you have, like I always say, it's people, then process. You need to have the people before you can set processes in. And don't aim for perfection. You need to get the people before infrastructure, people before the process. You need to get the team
Yeah.
of the, because this is multidisciplinary. As much
so
as
one question I had, which is the last question, more like learning from where there are established vascular malformation clinics. One of the good points that Luke brought up is having a patient advocacy rather than us advocating, and having a patient advocacy group and things like that. Are there any well-known charities that is there in either Australia or, I know there isn't anything in SG, but things like that, do you engage them? Do you think that will be a viable solution for us in India? Maybe engage Rotary and say, Rotary will do a walkathon or something.
it comes down to awareness, right? I mean, there are support groups. I know that there are support groups in different geographic, but then those support groups have look, there's a huge local impact, and so if that's something that can work for you, for sure. It may not work for every situation where there's already established. Like we're not looking for the support groups to provide. Like there is one support group that is happy to provide us with a laser machine. That sort of thing is different to
We
where
are not there.
Exactly.
We are having
So-
needles with bleomycin. We are not there in best and laser machines.
That's exactly what I'm
we
saying.
just
So
want to do this first.
it's a local need,
Get those patients to come
and
to
get
us.
them to, yeah, for sure. It can't hurt,
Yeah.
right?
I think we have run out of time, even though we can talk about this all day. So yeah, I think we'll all agree that the vascular anomalies session was fantastic. We had some good learnings. So I think this is just the first page or the first chapter. I think we should go on and take this further in our own practice, and I'm sure next year we will have a bigger, longer session with more interaction just for vascular anomalies. Thank you very much.
Thank you.
Sorry, if I may just add, we've actually registered an Asian Society for Vascular Anomalies to cater to our Asian and Asia Pacific region. Please watch for the space. I know it's taken quite a long time for us to get going. We've now finally managed to get a secretariat. So we are going to run some webinars. We're going to run a conference. And so please disseminate it to your colleagues, not just within IR or radiology, but your dermatologists, your surgeons, your oncologists, because it is going to be a multidisciplinary society which sort of like mirrors ISVA, but we feel that to actually cater to the needs of the Asia Pacific region, we needed to actually have a society run by people like us for our people, for our children and our children's children who need this management.
Probably we'll approach you through ISVR.
Yeah, well, I will go through ISVIR, but please just know that there is such a society now that's been registered. We are ramping up over this year, and we should have something. We'll get in touch. We'll definitely be in touch. So, Satish is going to be our point of contact. Thank you.
Thank you so much. With all talks concluded, I thank the chairperson for being in the session. And thank you for your patience. As previous session extended slightly, we'll be taking about 10 minutes from the next session. We apologize for the delay. May I invite Dr. Murthy Chennapragada to begin his talk on SPIRE.
Thanks, everyone. Thanks for your patience. And I'm not going to take too long. This is more of an introduction to the Society for Pediatric Interventional Radiology, which I'm been a part of and very proud member and executive and the past president of the society last year. And the whole idea of what pediatric IR is and what the specialty means. And I'm just going to try and sort of introduce this, the society to the membership here. I'm going to start with a little example of a little child who presents with a massive hematemesis. And most of IRs in this room would have been in the situation where at some point in time we may have been called in to help, and all these questions pop up. Well, how do we do it? When do we do it? And if you're not in a big volume center, these are all valid questions. Has it been done before? What can go wrong? And this is not just a technical dilemma, because IR, as we know, is not just procedures or techniques, but it is clinical medicine. How do we manage this child? How do we manage the medical condition and complications that may arise out of how do we aim for success? And that is the true reality of pediatric IR. It's a small specialty, it's a niche specialty, but it is not an uncommon specialty because these are diseases that can occur. Why is it relevant in Asia Pacific? It's because more than half of the world's population resides in Asia Pacific, and nearly a quarter of the population is children. It's a massive population. And what is the pediatric medicine that is catered to this population? Very, very small. It remains limited even in large children's hospitals, where rarely you have pediatric radiology, leave alone interventional radiology division. This is not a gap in ability. We are all able to provide. This is not a gap in the skill set, rather it is a gap in support and connectivity. Most of our practices in Asia Pacific are mixed adult pediatric IR practices, and therefore limited case volumes. And to be able to tackle these, it is the resource variability that affects this. And then biggest problem is the training pathways, which have always been informal in this part of the world. Society for Pediatric Radiology has its origin in the last decade, or a decade and a half, I should say, arose out of the idea that we need to have a dedicated thought process for looking at children and catering to their needs. And so a group of pediatric IRs, or IRs interested in pediatrics, came around to start this society in 2009. At this current point in time, we're about 440 members around the world. It's largely North American and European centric. And as you can see, Asia Pacific, there we constitute only about 7% of the membership. And that's a very small number. And that again reflects on how the access is limited. I'm very pleased to note that the last meeting that we had in Sydney, we had more than 50% attendance from Asia Pacific. That reflects that there is much more interest, much more focus, much more need for pediatric IR as a specialty in this region. The society is not an elite group. It's not an exclusive society. It's not just limited to centers that do a lot of pediatric. It's actually a global platform for every IR or any IR that treats a child, whether it is once a day, once a month, or once a year even. The society has a wide range of membership opportunities, particularly for the trainee members and the associate members. It's actually free to register, and the general members are also eligible for subsidized due if you're from low-income countries. What the society membership gives you access to is real-world expertise. People from facing similar challenges around the world that have had perhaps a bit more experience, perhaps have experience in building services and how to, that can provide guidance on building these services and providing guidance and support. Membership will give you access to education, attendance at the annual meeting at a subsidized fee, access to webinars, which are varying topics of pediatric IR relevance. There's opportunities for knowledge about training pathways, fellowships around the world. There is a members forum where you can actually post your case and seek opinions from pediatric IRs around the world, perhaps somebody who has done a few more cases that you have done. In pediatric IR, if you have done one case, it's a rare case. 2 cases, you've known some. 3 cases is a case series. 5 cases, you're a world expert. And that's a reality. Many of you may be thinking, we don't have the volume, we don't have the resources, we don't have a formal pediatric IR program, and that's exactly why SPIR matters and SPIR helps the centers. The idea of the society is to build context-based protocols, build faculty exchanges, facilitate exchanges between departments, between services, build capacity, and come up with shared solutions. It is a mutual way of learning and teaching each other. It's a way to collaborate and contribute. We have an SPIR global outreach program that we are actively pursuing, where we encourage regional centers to have exchange programs where we have a group of individuals that are interested in coming out and volunteering for these workshops or a day kind of interaction, so that we can support innovation and learn from each other, come up with shared solutions. More importantly, provide advocacy for children that is on a global scale. Children need this support and improve access to image-guided care everywhere. Please go onto website. This is your QR code for the website for membership. Please go through the website and consider joining the society. Most of us did not choose to become pediatric IRs, pediatric IR founders, because perhaps you encountered a difficult case, or perhaps a child that came to you with some problem that you solved, and that's what you remembered. And it's not the technical skill that is enough. It's actually the mentorship, the shared values, and the community that keeps us going. So I would really welcome you all to become members of the society and share your values and skills and ideas with the other members around the world. And I'd like to thank the organizers again for this opportunity to introduce the society to you all. And I hope to see you all at the meeting later this year. Thank you.
Hello, and thank you once again for having me. We're going to talk about management of venous thrombosis in children. I have no disclosures. So when we look at venous thrombosis in children, we have to ask ourselves some of these questions, and these are some of the topics that we'll actually touch upon. Is why should we treat DVT in children? What's the management of a lower extremity DVT? Current controversies, including anatomic variants, filters, stents, medical management afterwards for your anticoagulation plan, and management of upper extremity DVT. So why is this so important for children? Well, it's because our pediatric patients have much of their life ahead of them. And so quality of life, if you actually do have post-thrombotic syndrome after having a blood clot, a deep vein thrombus, then you actually do have to worry about how they're going to be living the rest of their life. What are the psychosocial effects of that? What's the cost of treatment? They may lose their central venous access at some point. And then if we stent them, what's that long-term stent patency and durability? So standard of care is still considered by CHEST guidelines, systemic anticoagulation, and then that really just prevents thrombus propagation, and then you rely on the body to break down the clot, and also graded compression garments. But now this is different, right? We have systemic anticoagulation. There's lots of advantages to this. We have lots of ways of preventing thrombus propagation. It's got a good safety profile, but there are disadvantages to it. And a lot of that is the fact that when we have thrombus there, it takes a while for that to clear. The longer it takes to clear, the more damage that actually happens to the veins. So what are our other options? So these would be catheter-directed thrombolysis, pharmacomechanical thrombolysis, and then mechanical thrombectomy, other means of intervention. So at our hospital, we have this DVT algorithm where a patient does present with symptoms of DVT, then we actually do our labs and our imaging, and then we'll actually have to look and get our hematologist involved and our interventional radiology department involved. So when we start with our clinical evaluation, remember, first, very few cases actually require an emergent endovascular intervention. This is a case of phlegmasia ceruleus dolens, fortunately extremely rare, but it can happen. And that's when you'd actually have to intervene emergently. So a detailed history and physical, looking at those precipitating factors, timing of DVT, extension of DVT is very important. And also, look at your whole patient, right? So you have to look at what are your patient-specific factors. This is my umama, okay? So she is non-ambulatory, increased bleeding risk. If we were to give her thrombolytics, I don't think she'd do that well with it. Now, children are great for this because they're younger, they're healthier, they're ambulatory, they can tolerate higher doses of anticoagulants and thrombolytics, less complications, they have the most to gain. And this is actually a picture of myself with Sanjaya from American Idol, and this is when I was younger and healthier as well. So this is actually, when you're younger, you're a much better patient. So duration of symptoms. You actually do want to try to treat as soon as possible. So acute clot, less than 14 days, and subacute clot with 15 to 28 days, that's probably your best window of treatment because it's soft clot and it's easier to get through. When you start looking at chronic clot, it's less of a thrombus removal situation. Sometimes that vein just dies, and now you're looking at an endovascular recanalization. So it can be a much more challenging procedure. Now, can you give the patient thrombolytics? Well, there are contraindications to it. Absolute contraindications are probably the ones I worry about the most when they have active internal bleeding, a recent stroke, or contraindication to anticoagulation. And then there are so many other things that actually we do call relative contraindications. But we do want to also know what's the extension of our DVT, because if it's a proximal DVT, and that's most cases iliac femoral, iliofemoral DVT, that's when we actually treat. When this extends above the inguinal ligament, that's when we actually are more insistent upon treating our patients. That reduces, your incidence of PTS. If it's distal in the calf, it's usually a benign course. And when we want to look at the extremities, whether it's the lower extremities or the upper extremities, we look at that with an ultrasound. And it's really good for mapping the vessels there. It is difficult, though, however, to see central vessels and difficult to evaluate for any venous anomalies. So with that, we'll get a CTV, MRV, abdomen, pelvis. That will be a better assessment of the extension of clot and also to look for some anatomic variants. So May-Thurner is being one of them. Now remember, about 20% of the population probably has May-Thurner. It really is only a problem in some patients, a very small percentage of patients that seem to just get tipped over into this hypercoagulable state and develop a thrombus there. But this is actually a case of May-Thurner where you can see that there's that impression of that crossing right common iliac artery over the vein, and you can see that the common iliac vein is then things are being drained from that left lower extremity via collaterals in the paravertebral plexus. When you recanalize that and open that up and stent it open, you actually can get nice flow through that. Now, there are also patients that have an atretic IVC, and atretic IVC is a little more complicated than that. And this is the patient that didn't have any IVC, an infrarenal IVC, and actually including the renals. Most of those renals drained through collateral vessels. And so when you have an atretic IVC, yes, you can sometimes open this up, and I would in those cases where the patient is not well compensated, I would advocate to actually open that up. But that is something to kind of keep an eye out for. Now, I bring this up because also, people have asked just, do you do periprocedural IVC filters, or do you do anything that's protective for PE? Well, you can place a filter, and I tend to place one and then remove it at the end of the case, whether I'm lysing or doing mechanical thrombectomy. However, remember that you can remove them 3 months later after they've been stabilized in anticoagulation, and IVC filters themselves can be flow limiting. Now, if you have clot that extends above the renal veins, we have used this other device called an Ono retrieval device, which is like a basket that comes down from the IJ and sits over the inferior vena cava, where you can actually catch thrombus from there. Now, for upper extremity DVT, I don't really do any protective measures. And atretic IVC, you may actually need to do any type of prophylaxis. Catheter-directed thrombolysis is when we're placing that multiple side hole infusion catheter, and we drip TPA for 1 to 3 days. You can use the kind that are unifuse, Craig-McNamara. Sometimes you have an ultrasound augmentation to that with ECOS catheters. You can do these venograms then the very next day and see what you've actually opened up, if you've dissolved any acute clot, and the residual clot itself can be treated with balloon angioplasty, so you can reestablish flow. There's a lot of advantages to it because it's local administration, but it's not necessarily the best thing. And then there are some disadvantages because it's long infusion time and they actually could be in the ICU for a bit. There's pharmacomechanical thrombolysis, which is angiojet, which we instill TPA and then we actually remove the clot during a rheolytic thrombectomy. And then we also do mechanical thrombectomy, purely mechanical with no thrombolytics. So we tend to use the Penumbra device, and this actually is a case you can actually see that's what clot looks like once you've taken it out. But we also have the ClotTriever, a Cleaner XT, so there's a number of different items on the market. Now, intravascular ultrasound is another tool that we use, and this is just a case of a patient with, here is the patent IVC. As we bring our intravascular ultrasound down, we see the May-Thurner lesion with that right common iliac artery crossing, then we see the occluded femoral vein, and then a patent femoral vein below. But most dramatically, you can see that what it looks like before when you have an occlusion, you don't see any vessel around the catheter, and then you see after you've actually reestablished patency, it looks much better. Then the question always is, do we stent, do we not stent? May-Thurners, I tend to stent, or short segment iliocaval vessels, but when do you stent in a pediatric patient? There's different kinds out there, but we'll see different kinds of stents that you can place. You want to make sure you just have something with good radial force and also one that you're comfortable with deploying, but you want to deploy a stent in a patient that is skeletally mature. So with that, we look at the Reiser classification for the apophyseal ossification. And the more medial that you get with the Reiser 4, the better you are actually stenting the patient. Again, stent versus no stent, how far do you stent the patient, kissing stents, and then we have patients here who actually have no intrahepatic IVC. Is that worth stenting? I'm not sure. So we can say that we do have some rates of patency up to 93% at 10 years. The follow-up on these patients continue their anticoagulation for about 6 months. We tend to do Lovenox for the first month because it does have an anti-inflammatory effect. We add aspirin and Plavix to the mix as well when we've stented and or very difficult recanalizations. I use Plavix as well. And we follow them closely with our clinic visits and ultrasound. And this actually is you can use any of these agents actually in children, but just to keep in mind that the DOACs are fantastic for actually giving to children because you're not giving any shots anymore and there's a lot less monitoring going on. Upper extremity DVT, we actually do have a venous thoracic outlet syndrome, which is really just an effort-induced thrombosis where that vein is being trapped, the subclavian vein is being trapped between the first rib and the clavicle. And when we have a patient come in with that, we will anticoagulate them, we will remove thrombus, and we refer them for non-emergent surgical resection of that first rib. There is no role for stenting in this case. You really just have to relieve that extrinsic compression. And also, in the acute thrombus, for imaging, we actually will do an MR. If there's acute thrombus there, it doesn't make sense to actually do dynamic movements. Once you've cleared out the thrombus, then you can image the patient with arms up and arms down to see if you've actually enhanced that.
Thank you.
We do get a CT via the MR via the chest to assess the extent of the thrombus. There are, if there are chronic symptoms, again, we refer to vascular surgery. We're almost done here, but this is actually a patient that when you have that thrombus there, you can do any kind of thrombectomy or thrombolysis with them. I avoid a balloon angioplasty here, And that's because of a request of the vascular surgeons, because inflammation can make rib resection a little more difficult. And then I do perform dynamic venograms just to confirm what we have. So here's the arm lowered, here's the arm raised, and you can see the collateral vessels and increased obstruction. And that's pretty much it. So we talked briefly about venous thrombosis in children, why we should treat them, what the management is of upper lower extremity DVTs, and some of the current controversies. Thank you.
Thank you so much for the wonderful session, ma'am. Moving ahead, we now invite Dr. Karamveer Chandil to speak on gastrointestinal bleeding in children, focusing on evaluation and interventional management. Welcome, sir.
So, good morning all. I'll be speaking on GI bleed in children. These are the learning objects for the day. We'll look into the age-specific causes, some causes where IR, there's need for IR. We'll look into some unique technical challenges and embolization strategy in pediatric IR, and some real-world cases from today. So, this pediatric GI bleed is not that common. The incidence is about 6.4%, significantly less than in adults. But importantly, around 80% of these bleeds resolve spontaneously, which explain why IR is involved in only a small but critical subset of the patients. But despite the lower incidence, mortality ranges from 5 to 21%. This is usually driven by the underlying pathology rather than the bleeding. Clinical presentation, upper GI bleed usually present as hematemesis or melena. Hematochezia is seen with lower GI bleed or brisk upper GI bleed. Sometimes patients may present with occult bleeding or anemia only. And in case of trauma or post-iatrogenic injuries, we may find intra-abdominal bleeding only. The anatomical distinction remain as in adults, the ligament of Treitz as the dividing line between upper GI bleed and the lower GI bleed. Upper GI bleed can be variceal or non-variceal. In the non-variceal type, we're dealing with the celiac artery branches. Lower GI bleed, we're dealing with SMA and IMA branches, and usually the iliocolonic and the colonic branches. Etiology, one of the important concepts in pediatric GI bleeding is that the etiology varies significantly with age. This is an exhaustive list, but from an IR perspective, not all of these are actionable. From IR point of view, practically we can divide the GI bleeding into arterial and the venous causes, because this directly affects how we manage these patients. In arterial causes, we are expected to do arterial embolization. Venous causes like variceal hemorrhages is typically related to portal hypertension, and which may require TEPS or portal decompression in some form. So we need to understand why pediatric GI bleed is different from the adult bleeding. One, children have a much smaller circulating blood volume, right, in the range of 70 to 80 ml per kg. So any small absolute blood loss will result in a large percentage of volume loss in these patients. And secondly, children physiologically compensate extremely well. They mount a strong sympathetic response in form of tachycardia and peripheral vasoconstriction, which help them maintain perfusion to vital organs. So blood pressure is often preserved until very late. And the child may appear deceptively stable despite significant or ongoing hemorrhage. But once this reserve is exhausted, they undergo a rapid sudden decompensation. So hypotension is a late and an ominous sign in GI bleed in the pediatric age group. So for us as intervention radiologists, this is important because we should need to have a low threshold of concern. We need to work together in close coordination with the clinical team and have early imaging or intervention before the patient reaches this point. First line, as in adults, endoscopy, it's diagnostic and therapeutic. We may be called in if endoscopy fails in case of inaccessible lesions, massive bleeds, or ongoing transfusion-dependent bleeding. We may be called in early in case of hemodynamically unstable kid, if the kid is not, it's a high surgical or endoscopic risk. Traumatic bleeds, because these are usually arterial in nature, post-pancreatitis, to manage pseudoaneurysms. Prior imaging, prior CT imaging is must in cases of pediatric GI bleeds, because this helps in earlier identification of the bleeding sites, help us recognize variant anatomies, improve the procedural success, and reduces procedure time, radiation, contrast, and fluid volume, which all are important factors in case of overall recovery and long-term effects of GI embolization in the pediatric population. Unique challenges, one is a small vessel caliber, because this results in small catheter and device option. We don't have much catheter and device option for these children. Children are more prone to vasospasm, and which require gentle catheter and wire manipulations. We should avoid repeated wire exchange. We should avoid very cold saline, which we often find in our cath labs. We should use saline at room temperatures. We should wait and reassess the situation if the vasospasm has occurred. Use small aliquots of fluid. And if at all it does not relieve, we might use intra-arterial NTG in the range of 1 to 3 microgram per kg or verapamil, whichever is available. These children also have risk of thrombus formation at both the access site and the sheath at the targeted vessel site, because most of the time the catheter at size, the sheaths may occupy most of the lumen, which can significantly increase chances of thrombosis formation in these patients. Then there are contrast and radiation concerns. For contrast, we should use weight-based dosing in the range of 5 to 7 ml per kg. Small liquids, diluted contrast. We should review our CT angio very well before we take these patients for DSAs. Radiation, low frame rates, collimations, minimize the DSA runs, store the fluoroloops, review them again and again, and a proper shielding. Fluid overload is also an issue with the pediatric interventions. We should use small boluses of fluid, monitor the input and output, avoid unnecessary flush volume, take help of the pediatric ICU people because they are well accustomed to it, how to use fluid in these patients. Equipment, the femoral access should always be ultrasound guided, smaller sheets, diagnostic catheters, small diameter catheters. We prefer GlideCath, Teramo catheters because they are soft and trackable catheters, smaller microcatheters. Angiography signs similar as in adults, active contrast extravasation, pseudoaneurysm, irregular arterial blush. But what is important with the pediatric population is the vessel irregularity tapering or spasm, because they might be masking bleeds. So we need to wait for some time, reevaluate these vessels again to rule out any bleeding. We need to watch out for hypervascularity because the normal pediatric bowel appear hyperemic. It's important to differentiate this physiological mucosal enhancement from bleeding. Next is DSA misregistration. Motion artifacts are an issue with pediatric population because respiration, crying, bowel peristalsis can mimic extravasation and obscure active bleeding. We may use glucagon by the dose of 20 to 100 microgram per kg, maximum dose of 1 mg. Embellishing agents as in adults, but we prefer microcoil, the smaller diameters, shorter lengths, and we need to avoid the larger particles or non-selective embellishing in these kids. The goal of treatment is to decrease perfusion, stop hemorrhage, not to devascularize the tissue. Upper GI, rich collateral circulation, so embellishing is safer in this territory. Front door, back door embellishing, the classic sandwich technique should be used. Lower GI bleed, sort of end arteries, higher risk of ischemia or infarction. We need to have a super selective vasa recta embellishing. Avoid proximal embellishing at all costs, and try and keep our microcatheter beyond the marginal artery as possible. Coming to some of the cases, it's a 10-year-old, blunt trauma abdomen, fast positive, came with hypotensive shock. Arterial and the venous phase shows liver laceration with active contrast extravasation. It took some time for us to cannulate the celiac artery. It showed diffuse spasm, but ultimately we were able to take the run, and it shows some active contrast extravasation from the right hepatic artery, selectively cannulated it, and did coil embellishing. So coils provide us good control in superselective embellishing, high precision, lower risk of non-target embellishing. Next case, it's a 17-year-old. The family has lost the twin brother about 2 to 3 years back for upper GI bleed post-pancreatitis. I was admitted with pancreatopleural fistula on right side, hypotensive shock, HB of 3.5. We could see on CT angio 2 closely placed pseudoaneurysm. One we were sure was arising from left gastric artery branch. Other we were not sure. We took the case for embellishing. The point of showing is one of the aneurysm could be cannulated very well. We could place our microcatheter across the neck of the pseudoaneurysm, place the coils. But next, for the other one, we were not able to cannulate. It was arising from mid-splenic artery somewhere, a small branch. We were not able to cannulate, so we just kept our microcatheter near the mouth of the branch, and we used glue in this case. So glue is effective but unforgiving. We can have variable concentration depending on how the flow dynamics are there in the artery. Risks, non-target embellishing, catheter entrapment, and should be reserved for experienced operators, and should be used only in situations where other embolic agents are not suitable. Next, GDA. So this point of GDA pseudoaneurysm, post-traumatic pancreatitis. The point of showing this case is that for upper GI bleed, we need to look for the collateral circulation. In this case, after embolition, we did a SMA run to check for retrograde embolization, retrograde filling of this pseudoaneurysm. So that was the point of showing this case, to do a sandwich technique in the upper GI. Next, this is a case with a 10-year-old disseminated tuberculosis, presented with massive lower GI bleed, HB 4.5 shock, past history of on and off loose stools for 1 year. Arterial and the venous phase shows active contrast extravasation in one of the jejunal branches. We took, for the DSA, selectively cannulated this jejunal branch, went as far as possible into this branch, and used PVA particles, just 0.1, 0.2 ml, just to introduce stasis into this branch so that we can achieve thrombosis in the pseudoaneurysm. PVA particle should be used cautiously, selectively, best suitable for tumor-related bleeding. There's higher chance of bowel ischemia if not super selective. So always ensure that you have a distal catheter position before use of PVA particles. 9-year-old, high-grade fever, melena, fallen hematocrit. This was a case, very high, we encountered a lot of vasospasm in this patient. One of the iliac branches was bleeding, so we were not able to reach to the branch. We used 0.1 ml of gel foam slurry just to introduce stasis again. So gel foam is can be used in situation where permanent occlusion is undesirable, higher risk of rebleeding, but we can take this trade-off with us. Next, it's just not endovascular ambulation. We can use percutaneous route for this 5-year-old hematemesis, fallen hematocrit, 14 mm pseudoaneurysm with a good neck to dome ratio from left gastric artery. So we used ultrasound to puncture the pseudoaneurysm, placed 0.1 ml of thrombin into this pseudoaneurysm to achieve thrombosis. So summarizing it, pediatric GI bleed is not a small adult bleed. Super selective embolization is the key. Radiation discipline is mandatory. Teamwork defines success. We need to balance hemostasis with ischemia, and early IR involvement saves life. Thank you.
Thank you so much, sir. Since we are running a little bit behind the schedule, we'll continue the talks without a break. You are welcome to quickly grab a coffee and come back as the presentations will continue here. Next, may I invite Dr. Saurabh Kumar to discuss biliary interventions in children, sharing practical insights and clinical experience. Welcome, sir.
Thank you for the kind introduction, and good afternoon, everybody. So, starting on the biliary intervention in children. So, we all know the pediatric biliary procedure differ from those in adults, both concerning typical diagnosis encounter and benign disease being the more common, and they often possess unique technical challenges. The key differences are the smaller caliber duct with a fragile duct wall, so there more risk of perforation during cannulation. The liver parenchyma is also softer, so more prone to bleeding during the tract dilatation. There is high risk of sepsis and fluid instability, especially in the neonates and in infants. The procedures are to be done in deep sedation or general anesthesia, and the radiation sensitivity is also an issue, so we always have to use a low pulse rate fluoroscopy, adequate collimation, and electronic magnification. Maintaining patient warm during the procedure is also a key factor, especially in neonates and infants, to prevent heat loss. And usage of chlorhexidine or isopropyl alcohol in place of povidone iodine should be advised. Iodine can be absorbed through the skin, affecting thyroid function, especially in the neonates and infants. So, common indications are diagnostic cholangioscopy in management of obstructive jaundice or recurrent cholangitis. Post-labor transplant biliary stricture management, this is the most frequent indication at our center, and pre-operative biliary decompression procedures. So I will be discussing the case-wise. Coming to first, the biliary triggers, as we all know, it's a neonatal cholestasis accounting for around 25% cases with variable obliterative cholangiopathy involving intra and extrahepatic duct. Though ultrasound, MR and scintigraphy are sensitive for 85% of diagnosis, but the gold standard remains an intraoperative cholangiogram. However, pre-op percutaneous transhepatic cholangiocystogram is a viable alternative and quite diagnostic, in which we on ultrasound guidance we puncture the transhepatic GB puncture is performed, and after installation of contrast, if we see passage of contrast in the duodenum and opacification of the intra and extrahepatic duct, this basically rules out biliary atresia. So, like in the third slide, we can see the GB appears to be dysplastic, and after the installation of contrast, there is no opacification of the intra and extrahepatic duct, suggestive of biliary atresia. So, the protocol for cholangiocystography is you have to always be a transhepatic GB puncture should be done along the long axis of the gallbladder. And once the position of the needle is confirmed and aspiration of bile, you slowly inject contrast. Head down can be done for intrahepatic duct opacification, and morphine can be used to promote sphincter of Oda response. So the axis should be along the long axis, transhepatic. In the second image, we see that there is biliary atresia, the gallbladder appears to be dysplastic, and no intra or extrahepatic opacification of the bile ducts. So sometimes you can identify, like in this case, after the puncture, there is the intra and extrahepatic bile ducts are seen, and there is opacification. There is contrast can be seen in the duodenum, but the ducts are very small and hyperplastic, which can be seen in biliary disease or Alagille syndrome. However, liver biopsy is confirmatory in these cases. Sometimes you can pick an infantile sclerosing cholangitis secondary to immunodeficiency and syndrome 1 histiocytosis, particularly in children, in which we get irregularly dilated ducts. Now, in choledochal cysts, as we know, there is a cystic dilatation affecting more segments of intra-extrahepatic ducts. Normally, biliary intervention is not prescribed, but in certain cases, like for decompression of large cysts or an infected and rupture cyst, we might have to do an intervention. So this is a case. In this, the patient present with 4 months patient present with large cyst. Antenatally, it was diagnosed as a mesenteric or duplication cyst, but on the CT we can see the biliary communication, and it was a large choledochal cyst, type 1 choledochal cyst. So there is the patient complained of repeated vomiting, failure to thrive, and inability to take feed. So we did the percutaneous drainage. This is the intraop cholangiogram. We did the percutaneous drainage with a 6 or 8 French catheter. After 1 month, the patient was taken for surgery. This is an intraoperative cholangiogram. This is the complete excision of the choledochal cyst, and the patient this is the resected complete excision of choledochal cyst, and the patient was further taken for hepatogenostomy was done in this case. Sometimes there is a rupture of the choledochal cyst. We have a large subhepatic collection, so we might have to drain it, and further it can be to remove the external drainage, we can have to do a puncture of the gallbladder duct was done, and rendezvous with technique we can place a plastic stent and remove the external drainage catheter. Sometimes in pediatric we can also do for percutaneous cholecystostomy, as is seen in adults in cases of acalculous cholecystitis, in which we have to do a transhepatic gallbladder drainage by the 6 French or 8 French locking loop catheter. Common indication is seen in patients with leukemia, in ALL, especially in pediatric BMT transplant center. These are quite common indication, and viral infection like of hepatitis B and salmonella infection. So malignant biliary obstruction is generally not, biliary malignancies are not very common, but we can often see a biliary rhabdomyosarcoma or lymphoma compression of the bile duct. So these are quite chemoresponsive, but in certain cases when there is associated cholangitis or when the bilirubin is so high, so we might need to drain it. Like this is a case of biliary rhabdomyosarcoma, solid cystic mass lesion at the hilum with proximal IHBRD and cholangitis. So we did a external drainage, and the patient is taken for chemotherapy and did well after the chemotherapy. So this is the most common indication, the biliary complication after liver transplantation. As you all know, the biliary stricture are a common problem after pediatric liver transplantation, with the incidence of 10 to 35%, around 35%, and untreated are often associated with high mortality and morbidity. Percutaneous treatment remains is considered safe and effective, and in most cases avoid the need of surgical revision or re-anastomosis. So we all know that basically strictures are anastomotic and non-anastomotic, and non-anastomotic are further classified as ischemic biliary lesions associated with HAT or ischemic type biliary lesion not associated with HAT. So these are the puncture in pediatric age group. These are common puncture needles. We use the NEP set 21 gauge or a micro puncture set with a 018 wire. So this is the anastomotic biliary stricture involving the stricture also involving the exgen, and also there is ascending stricture involving there is segmental separation of segment 2 and 3 duct. So we did when we puncture the initial duct. This is the cholangiogram. We see faint opacification of the jejunal loop. We can see that it's going into the jejunal loop, but with this we weren't able to cross the biliary stricture. So we puncture the inferior segment 3 duct. So with this we are able to cross the biliary stricture. We balloon dilate with semi-compliant balloon of 8 mm. And important internal catheter in the first stage, one we are able to internalize, but the segment 2 duct we weren't able to internalize. However, in the second setting after the 2 months, we are able to internalize both. So this is the only image I have. After that, I lost the rest of the images. So we are able to internalize both the ducts, and the patient we remove both the catheter after 3 months, and the patient is doing well. So technical modification in infants, sometimes we use 5 French catheters. So the problem is the hub. So this is the angiographic pectoral catheter. So we cut the back side of the catheter and can place an infant feeding tube hub to connect for a connector. And in this case, the 6 French or 8 French catheter is cut and acts as a hub for the 5 French angiographic pectoral, especially in the neonates when the external biliary drainage requirement is there. So this is the other case with the left side. We puncture the system, we cross the system, balloon dilatation, and this is an internal external catheter. So sometimes there is associated both stricture and leak can be seen, but both can be managed by putting a internal external catheter in one setting also. So sometimes there is bile leak and there is subhepatic collection, so you have to initially place a external subhepatic drain. So after, after the initial control of the infection, you can always do a PTB and internalized catheter. So putting a catheter for 6 to 8 weeks also helps in controlling minor leaks. So protocol for at our center for basic structural dilatation, if initially we took if the weight of the baby is less than 20 kg, we initially start with 8 French, then we regularly dilate it after every 2 to 3 months. The size of balloon we use is generally 1 millimeter larger as compared to the normal upward diameter of the intrahepatic duct, and each dilatation lasts for around 10 minutes, and we have to keep the dosage to the minimum. Endpoint is when the resolution of the stricture or there is minimal stenosis less than 20% of the lumen, or when there is complete passage of contrast from the bile duct into the bowel loop within 3 months of cholangiography. Like in this case, there's a complete blockage. We crossed it with the NEFSET and we balloon dilate. Balloon normally we use semi-compliant balloon alone, not the stiffer one balloons. And this is a 3-month follow-up. There is regular adequate passage of contrast into the across the edges side. So we remove the catheter at 3 months. The baby is doing fine. So just to conclude, pediatric biliary intervention requires tailored technique due to smaller anatomy and unique congenital pathologies. Ultrasound-guided percutaneous techniques remain safe and effective even in infants. And post-transplant biliary intervention enables bridging to repeated transplantation and long-term remodeling of the strictures in growing children. Thank you.
Next, we invite Dr. Jinesh V to speak on renovascular hypertension in children, covering diagnosis and management strategies.
Good morning, all. So my topic is renovascular hypertension, especially in pediatric population. So as we know, pediatric hypertension is defined as systolic BPM above the 95 percentile. The importance of detecting this as a strong predictor for hypertension in adulthood, and these children, they go mainly for cardiovascular complication. They'll have, especially they'll go for LV failure, LV hypertrophy, and also hypertensive encephalopathy, and later they go for renal failure. So they should be detectable easily, and if you treat it early, because they are reversible cause, unlike the essential hypertension in adulthood, where the changes of reversibility are not that much pronounced. So it's important to detect this renovascular hypertension, and of pediatric hypertension, the percentage of renovascular hypertension is more. It's almost in tune of 1 to 2% adult, whereas in pediatric it's almost 10%. So their numbers are more, and you have to treat it early. And so it's crucial that you have to detect early and also manage very early itself. So the causes are multiple in type, and we can classify into inflammatory and non-inflammatory, because the management is entirely different in inflammatory cause of renovascular hypertension versus non-inflammatory cause. So inflammatory, the classical subtype is Takayasu disease, and next comes Kawasaki and Pan. So most common is Takayasu arteritis. And next, in non-inflammatory category is the fibromuscular dysplasia. That's a classical prototype. And we have syndromic causes like tuberous sclerosis. The most common we see is necrosis neurofibromatosis. And venous causes are not that much, but if you have renal vein thrombosis, especially post-nephrotic syndrome, patient patient go for renal thrombosis, and they'll go for hypertension related. And you can have renovascular hypertension without renal involvement also, because the aortic stenosis is there. As the flow of the kidneys will get, perfusion will be reduced, and little hypertension, especially if there is supravalvular narrowing is there, or there is a coarctation is there, or mid-aortic syndrome. Renal arteries will be completely normal, but you can have involvement of renal arteries, but it may be normal also, and still it's classified as renovascular hypertension. The cause is renovascular, even though the anatomy is problem is in the aorta. So that's how we classify, and because the management is based on this classification. So imaging, as we know, there is ultrasound, CT, MR, and scintigraphy. Usually prefer for ultrasound as an initial modality, and also as follow-up. Patients who do angioplasty or other intervention. In some patients, we need recurrent follow-ups. You do ultrasound, and ultrasound is not that characteristically. You go for non-contrast MR angiography, 3D, and multiple sequences are the non-contrast angiography and follow-up. CT you will do usually for the initial part. There is an issue with the contrast and also with the radiation part, but to characterize better, CT may be helpful. There are other newer modalities that are coming, like contrast and ultrasound, intravascular ultrasound, etc. But CT, in our institute, we usually go with CT and follow-ups with ultrasound and non-contrast MRI. So the treatment, as we know, the medical management is the first line. You start on multiple antihypertensive. There is an issue with ACE inhibitors. We cannot start all the patients on ACE inhibitors, so it's probably a beta blocker and a central similar lighting like you had to start on clonidine or called Arcomin. And then next comes, we had to do concomitant endovascular management. Angioplasty stenting is not that preferred in pediatrics because of the size of the kid, size of the vessels won't regrow much. So it's usually angioplasty is the preferred thing. Only in selected cases we do stenting. And surgery is done in cases where the complex cases, the long-term cases are done. So this is a general management treatment for renal vascular hypertension. So it's always medical management. In adults, we start medical management, go to step 4. That is JNC 7 guidelines, go to step 4. When pediatric, in the step 2 itself, we'll try to open the revascularize the kidney because reversibility is better in early stage for revascularization of kidney compared to adult population. So TACASO, as you know, it's the most common, especially in the Southeast population. The patient can have systemic involvement and can have multiple vascular territories, and you can have bilateral involvement with aorta, without aorta, etc. All types of permutation combination can be possible in TACASO, with active phase, inactive phase also, with improved reduced renal function, with small kidneys, normal size kidneys. So there are multiple permutation combinations that can happen in TACASO. And the factors that you take into consideration TACASO is that is the aorta involved or not. Aorta is short segment and long segment involvement. Bilateral renal arteries are involved. The stage of the disease is active or inactive phase. Is the kidney preserved? Kidney size is preserved or not? Is small size, less than 5 centimeter kidney. The kidney itself is a problem of hypertension. It's like a tertiary hypertension. There will be so many juxtaglomerular apparatus hypertrophy in the kidney. You do the renal revascularization, there is no point because there will be autonomous secretion of renin from the kidney by the juxtaglomerular apparatus. You have to knock out the kidney either endovascularly or by surgically. So it depends on multiple factors how do you treat a renovascular hypertension pediatric population. So in this case, there was a 12-year-old boy who had severe hypertension and ESR was elevated. He was on 3 antihypertensive. You can see there is renal artery stenosis and increased elevate ESR is likely to be an inflammatory cause of renal vascular hypertension. So you must look for TACASO. You can look for Kawasaki. The age is slightly higher for Kawasaki disease. And also PN sometimes can happen. So in this case, it was diagnosed TACASO based on his clinical findings and other findings. But the problem is that it's an active disease because ESR is heavily elevated. So in active disease, it's not a good idea to always do revascularization because the high risk of complications like dissection, rupture, etc. can happen. So usually we'll try to reduce the activity of the disease. So start on steroids or steroid-sparing drugs or interleukin-6 like inhibitors like tocilizumab. You control the activity and do later angioplasty. And TACASO, it's less preferred to do a stenting. If you do stenting for TACASO, it's an inflammatory disease, so it will recur. Instant stenosis will happen, instant thrombosis will happen. So always the idea is to do multiple repeat angioplasty rather doing stenting in TACASO disease. The disease will recur, the stenosis will recur, but again you can do angioplasty after 6 months, 1 year, 2 years, etc. So that's the routine to do in TACASO. It's never a case of stenting unless you do complication during the procedure. So this follow-up was done. We did angioplasty for that. It's a plain vanilla angioplasty. We did follow-up. 1 year he was fine. After then again restenosis happened in the 3-year follow-up. You do a repeat angioplasty. That's a norm of TACASO. Go on doing repeated angioplasties in such cases. But some cases where the disease activity is there also. For in this case, it's a 12-year-old patient who had LV dysfunction. BNP was highly elevated. He has grade 2 papillary edema with highly elevated ESR. So in this patient, if there is a LV dysfunction is there or there is a flash pulmonary edema is there, grade 3 for papillary edema is there, or there's hypertension encephalopathy is there, you can disregard the activity stage because they are hypertension emergencies. You have to treat that acutely. So you can put on steroid, but you don't have to wait for the ESR to drop down. We can start angioplasty, and you don't have to angioplasty to maintain the angiographic integrity. You just have to do small balloons, 2 or 3 millimeter balloons, and just drop the gradient. The gradient maybe drop the gradient to less than 15 or 10. That's the end point. You do not have to have the complete angiographic picture to be nice in this patient. So if you do that, the patient will recover, the LV dysfunction will be improved, and the patient can improve. And you can start the patient later on steroids also. TACASO can come in multiple flavors. This was a case of mid-aortic syndrome. The aorta was also involved. I think the video is not. So there is involvement in aorta plus renal artery. So if there is involvement in aorta plus renal artery called mid-aortic syndrome, it's not a good idea to do angioplasty for aorta because the renal is inflammation and thrombosis. So in this case, the best idea is to go for graft. So the surgeon's first place, graft was placed from the aorta. And in this also cases, the patient will again go for recurrence, and this patient again had graft stenosis in the upper and lower end of the graft. There was graft stenosis, and we had to do angioplasty for the graft stenosis. So these patients, the disease recur because of the activity will go on recurring. And some in late TACASO, the TACASO in late phase, burned out phase, etc., also can have mid-aortic syndrome. In these cases, you can do intervention. And if this mid-aortic syndrome is always a better idea to go for surgery. But if the patient's age is less than 18 or in pediatric age group, you can do multiple small angioplasties and just do balloon angioplasties of the aorta or the renal vessel till adolescent. And after the patient reaches the adolescent, after 18 years, it's a good idea to do the surgery for the patient. And surgery after that, you can do arterial angiography for the complications. So in mid-aortic syndrome, it's always a better idea to prolong the do multiple angioplasties till the patient age attains at least 18 to 19 years, and after that you can do surgery for this. That's regarding Takayasu part. Fibromuscular dysplasia, it's straightforward. It's non-inflammatory. ESR won't be elevated. It responds well to angioplasty. So it's a straightforward. You do the angioplasty, and the patient responds well. There's no recurrence in case of FMDs. But it can come with multiple flavors, like FMD with renal aneurysms. Aneurysms will shower multiple embolisms in the kidney and produce infarcts. Though you have to coil off these aneurysms in the FMD. Or it can come from segmental FMD, where one polar bar transient involved. So you may miss an ultrasound because if you do an ultrasound, lower pole, RA, everything will be normal, upper pole will be involved. So it is usually missed in ultrasound. So CT or DSA can see that there is an upper pole involvement, you could do angioplasty and the patient recovers well. The aortic involvement, coarctation aorta, again this comes with multiple flavors, coarctation with the aortic valve involvement, without involvement. If it's a cause of renovascular hypertension, you have to open the vessel, either angioplasty or stenting. So in this case, there was a coarctation with irregularity here and the kidney was small, and we resorted to the angioplasty and stenting of the aorta. Aortic stent graft was placed. You can, in pediatric, you have Z stent that you can serially expand the stent over time, and so that it grow. If you want to do angioplasty stenting, you can re-stent the stent after some time also. Similar renovascular hypertension also, this is a cause of hypertension. The thing is that you can see that if it's a congenital cause, there will be collaterals from the iliac vessels. So in this case, there was iliac collaterals. So from the iliac vessel, because the kidney ascends from above, so congenitally itself, the renal artery knows it takes collateral from the iliac vessel. So that's a reminder that the issue happened during congenitally. So most likely it could be renal fibromatosis or other cause like Williams syndrome can have this appearance. Do angioplasty, patient improves, like in this case. You don't have to open completely, you just have to reduce the grade. In this case, neurofibromatosis angioplasty was done. This was a case we did yesterday. Again, neurofibromatosis angioplasty was done. Again, Williams syndrome is also one cause where you can have supravalvular narrowing like this. So the output failure will happen, and as a result, this cases also present hypertension. The treatment is you have to do surgery. And they had to replace the aorta in this case, Williams was done. And the last case is like this patient again has hypertension. The cause was different, and this case was renal AVM. So there will be large shunts that will reduce the perfusion of the kidney and produce hypertension. It was plug embolized. So this, so the results of a case of 37 cases is similar. The pediatric Takayasu, you had to do multiple interventions compared to other things. So to conclude, you should have a tailored approach. Takayasu treats where you have to repeat the angioplasty. FMD1 angioplasty, patient response will be there. Mid-aortic syndrome, it's better to go for surgery. Endovascular is just a prime for surgery. Long-term aortic involvement, you go for surgery. And you need a multidisciplinary team for optimal patient outcomes. Thank you.
Thank you so much, sir. Just to keep everyone informed, as the session run a little longer, we'll be concluding the session at 12:50. We request everyone to please hold their questions. We'll be taking the questions at the end of the session, and thanks for understanding. Now, may I invite Dr. Karun Sharma to take us through ablation in children. Welcome, sir.
Thank you very much for the invitation. It's a pleasure to be here to talk to you about ablation in children. And I have no disclosure. There are many ablation devices available to us. I will speak about the ones that I'm most familiar with here. In case I get beat by the bell, I thought I would just give you the punchline here. This is the take-home message. Thermoablation has emerged as a valuable, minimally invasive treatment in children with cancer. Over the last 30 years, especially the last 10 or so, RFA, microwave, HIFU, LIT, as well as others, have been increasingly applied to treating tumors that are both benign and malignant. We'll go over the mechanisms of how this is done, but that's a lecture by itself, so I'll provide a quick, brief overview of that. It's important to understand the historical perspective of how we got here over the last 30 to 35 years. And this all really began in the early 1990s with the successful thermoablation of osteoid-osteoma, which provided the proof of principle that needle-based heat could replace surgery in the treatment of these benign lesions. Once that became standard of care in the early 2000s, interventional radiologists started applying the same concept to malignant tumors. Although there were several case reports back then, it was still considered experimental. A lot of progress was made in the 2010s because of improvements in technology and imaging guidance, and that really led to the first sort of review article, the systematic review in 2014 by Gomez et al., and that sort of is really where the field took off. There was a second 2019 large meta-analysis and review that provided the statistical, I wouldn't call it evidence, but the impetus to keep this going. And it also showed that children who received ablative therapies had significantly higher 2-year tumor-free survival. And that was a big deal, at least in my opinion. And then the last few years have been really about mainstream integration. Most children's hospitals have dedicated interventional radiologists now in the US, and there's a close collaboration between the oncologist and the interventional radiologist, and the patients are discussed during multidisciplinary teams to see where ablation best fits and what type of ablation best fits. I just wanted to show this quickly. These are sort of the key studies in the last decade that have really provided us, I wouldn't say strong as adult evidence, but decent evidence to sort of keep going. All of them have shown that the benefit is much higher than the complication rates. Mechanisms, again, we won't cover through all of these, but just the relative pros and cons of different mechanisms, whether they be heat-based or cold-based. Radiofrequency ablation is the best characterized in the pediatric population. It's been used the most, and it's the still continues to have the best track record. Microwave ablation caught up a bit later, and it's the newest in children as far as the heat-based modalities, best reserved for large tumors. It's faster and does not succumb to heat sink effect. Cryoablation is extremely versatile, has been used in pediatrics in many tumors, and has the unique advantages of the visualization of the ice ball and also being less painful. We won't talk about LIT. It's a very focused ablation modality, highly used in neurosurgery. Focused ultrasound, which I do a lot of, is very limited in availability. It's very early on. And PEF is extremely even more new. So in terms of pediatric clinical applications, I mentioned osteoblastoma. That has led to ablation for osteoblastoma and chondroblastoma. Desmoid tumors are the next sort of challenging tumor, and this has led to fava lesions and vascular anomalies. And on the malignant front, we have osteosarcoma, soft tissue sarcoma, largely pulmonary metastases and other metastases, but it has been reported in hepatoblastoma, renal tumors, and painful bone metastases. We won't talk about osteoblastoma much. We've seen that this is very well known in the literature. In fact, it has replaced surgery and other minimally invasive techniques. And this is just to show you that osteoblastoma can be treated by radiofrequency ablation here on the left. It can be treated by cryoablation. It can be treated with HIFU, and we've done it all. I reserve the cryoablation for locations that are a little more tricky and next to critical structures, but we use RFA as well. Desmoid tumors are a little bit more challenging than osteoblastoma, obviously quite a bit larger, more painful, more symptomatic, and surgery is not really a good option here, neither is radiation or medical therapy. And the newest medication for this, which has been well studied and has good response in adults, is currently under pediatric trials. And there's a long history of ablation in desmoid tumors. The first papers were not so much in adults, but we have this now more recently in a pediatric population. So we have radiofrequency ablation on the left. We have cryoablation in the middle. Dr. Ganji's study, CryoDesmo, is really the first one that really was a true study that showed this. And on the bottom, we are, in our experience, have treated about 10 patients with focused ultrasound or HIFU. And this is the latest paper from a pediatric-specific population by Dr. Sheikh in Boston. So just a few examples here. This is cryoablation for a Wilms tumor, a patient that I treated many years ago. And as you can see from the history, this is really, when we were thinking this might be experimental therapy, this is really the last-ditch effort. The patient has had multiple recurrences, has had surgery, radiation, chemo, et cetera. And by the time he got to us, this was sort of his fifth or so relapse. And this responded very well to cryoablation, and cryoablation works fairly well in the lungs here with postoperative changes here seen at 6 to 12 months. Now, we want to switch a little bit over the next couple of minutes. Ablation, image-guided ablation has and can, in my opinion, replace a lot of surgical intervention in kids. Less invasive, yes. Quicker recovery, yes. Ability to perform repeatedly, yes. But we also know that there are limitations to ablation. And this is where the next frontier, I believe, will occur. We've had advances in electrode design, we've had advances in imaging integration, but really what's exciting over the last few years is this evidence of combining ablation with immune activation, or having ablations affect immune activation. And so the combination therapies is really, I think, what the future holds. And I'll just cover a couple of patients from work that we're doing at Children's, where we're trying to combine ablation in the first sort of group with focused ultrasound and hyperthermia with doxorubicin containing liposomes to deposit the doxorubicin specifically in the tumor and avoid systemic toxicity. And the other one where we're trying to combine ablation with immunotherapy. The idea here, or the hope here, is to create an in situ vaccine with the ablation so that the immune checkpoint inhibitors can be even more effective. And we are new in this clinical trial, but we have now treated a couple of patients. I just want to show you the very first patient that we did. This is a patient, I haven't listed his entire medical history, that would take up about 2 or 3 slides, but an 11-year-old with adrenocortical carcinoma who's had multiple resections, chemotherapy, radiation, and this was again at this sort of court of last resort. And what I want you to see in the bottom imaging progression here is the target lesion that we treated and the non-target lesion, which was not treated by ablation, and sort of this abscopal effect that we can see over the first year or so. And essentially what we've seen here is that the targeted lesion, the treated lesion, has decreased significantly in size, changed in Hounsfield units, and is PET negative. And then the latest, the non-targeted lesion also has decreased in size, essentially non-visible, no PET activity. So to summarize, these are the main take-home points. Minimally invasive tumor control is offered. We are using it much more commonly today than we were just 15 years ago. It has broad tumor applicability, benign as well as malignant tumors, primary as well as metastatic disease. Has rising clinical adoption and has improved outcomes and safety because of both technological advances in probe design as well as the imaging. These are my references, and thank you.
Thank you so much, sir. May I now invite Dr. Madhusudanan KS to share his tips and tricks in management of Budd-Chiari syndrome in pediatric population. Welcome, sir.
Good afternoon, everyone, and thank you. So Budd-Chiari syndrome is essentially obstruction of the IVC or at the level of hepatic veins or a combination of these. And in children, so this has been our experience, and most of these children present with ascites, and then there may be associated organomegaly, typically enlarged liver and enlarged spleen because of portal hypertension. So the main imaging modality which we stress is ultrasound, because in children we do not want to expose them with radiation with CT, and then MR takes a longer time and gives less information when compared to ultrasound. So ultrasound, using ultrasound we can see the hepatic veins, the level of obstruction, we can evaluate the IVC, and then we can plan the intervention as well based on the ultrasound image, and we rarely need any other imaging modality for either making a diagnosis or planning the further management. So that's why we stress more on ultrasound, and especially in pediatrics it becomes very important as well. On ultrasound, the diagnostic feature is mainly the direct signs where we see directly the hepatic veins or the IVC. So we can either see thrombus within the hepatic vein, which is seen in the acute setting of venous thrombosis, but more commonly we encounter subacute and chronic types of Budd-Chiari syndromes, like in this case where there is a long segment occlusion of the middle hepatic vein, or we can see a membranous occlusion of the IVC, or complete cord-like appearance of a right hepatic vein. So these are the various appearances what we see in ultrasound in a child with Budd-Chiari syndrome. So these are the direct signs which will help us make a diagnosis of Budd-Chiari syndrome. And then there are a few indirect signs, the typical comma-shaped collaterals, enlarged caudate vein and enlarged caudate lobe, and there may be features of portal hypertension in the form of ascites and splenomegaly. So all these features will help in making a diagnosis of Budd-Chiari syndrome in children, and then based on this we can easily plan the next set of interventions which need to be done. So the IR protocol, this is the IR protocol which we follow. We just try to see if we can open up the intrahepatic IVC and the hepatic veins wherever possible. And if you are not able to do that, only then we go ahead and then do the DIPS, which is the treatment for portal hypertension. And if all these fail, liver transplantation is the next standard treatment. Hardware, unfortunately, we don't have any dedicated hardware for children, so we have to, use the same hardware which is available for adults. So typically, we use the same transjugular liver set, the ROOP set, which is available, and then again the stents, whenever possible, we use. And then even the balloon catheters and the balloon-mounted stents are the ones which we use typically, which is available for adults and nothing specific for children. So the approaches which we use is typically transfemoral whenever there is IVC obstruction. So IVC obstruction or IVC stenosis. So this is what we do. We go through the transfemoral route, do a venogram or a cavogram to see the level of obstruction and try to cross it. And then for hepatic veins, what we typically use is either a transjugular route or a transhepatic route. Because children, they are small size, liver is also of small size, it's easier to puncture the hepatic veins directly. And often if you see a good length of normal hepatic vein, it's easy for us to directly go ahead and puncture it transhepatically and then do our procedure completely. And then, because again, as I said, the devices which are available for the transjugular are adult sizes, and if the child is small, 2 feet or 3 feet, then it becomes very difficult to use a 2 feet long transjugular liver colapento needle or the sheath. So it becomes very difficult. So that's why we try to use the transhepatic route wherever possible, but if not, then we might have to use a transjugular route as well to, recanalize the hepatic veins. And then if you are planning to do a TIPS or a DIPS, then transjugular route is the only option available. So to stress again the role of ultrasound, so as I said, diagnosis is the most important thing which we make on ultrasound appearances. Then even during the procedure, the initial puncture is ultrasound guided, whether we puncture the jugular vein or the transhepatic vein. And then many times it's important to visualize, even during the procedure, we visualize our devices under ultrasound, which will help us in crossing the obstruction. So like in this case, we can see there is an IVC obstruction and we can direct our angled dilator, and then we can easily help us cross the obstruction and reach from one lumen to another lumen. And so this will help us cross the obstruction confidently, and then instead of taking our wire in a different way into the pericardial space or a retroperitoneal space. So ultrasound is very helpful in during the procedure as well. So similarly, in the case of transhepatic occlusion, we can see that this is our catheter and wire, and we can see that we are, if we puncture it across the membranous obstruction, we are going to reach the IVC. So ultrasound gives us more confidence when we are trying to cross the obstruction. So this is when we are doing from the transjugular route, we can see the colapento needle, and we can change the direction of the colapento needle according to the direction of the vein which we need to recanalize, and then that will help us cross the obstruction. And then when we are doing DIPS, we can see that the whole, because in DIPS, in Budd-Chiari syndrome, while doing DIPS, the main limitation is the enlarged caudate lobe. We have to traverse a long track from the hepatic vein or the IVC to the right portal vein. So this is a long track, and then we take ultrasound as a help. We can direct the needle, change the shape of the colapento needle to adjust to the direction of the track, and then we can puncture the portal vein. And then lastly, when we need to recanalize a thrombosed DIPS, then again ultrasound is helpful in hooking the upper end of the DIPS stent using the colapento needle and catheter and wire. So the next step is the crossing of the obstruction. We use all combinations to cross the obstruction. So we usually start with the soft end of a wire, but because all these are fibrotic lesions, it's very difficult to cross with the soft end of a wire. So we often need to use the hard end of the wire. Then again, using ultrasound, once we are confident that your puncturing of the needle will reach the other end of the lumen, then it's easy for us, and then we can use the hard end of the wire. And then we also take help of the dilator, because once we wedge the dilator against the obstructed point, it's easy for us to poke across the obstruction. And then sometimes we modify when you are using a transhepatic route. So while using a transjugular route, we have the colapento needle, which gives us adequate support. But when you are using a transhepatic route, getting an adequate support becomes difficult. So we have locally modified an 18G Chiba needle to give it curve, and then that can easily go into a sheath, and then we can use it to cross the obstruction. So all these techniques we use to cross the obstruction. And then, so uncommonly, so our main aim is to keep at least one hepatic vein open. So that is the main purpose. And then even if a child comes with the suspicion of Budd-Chiari syndrome, and if we see at least one hepatic vein open, we don't, intervene, because we see that one hepatic vein is enough. But uncommonly, we might have to do a diagnostic venogram. So this was one such case where we saw the anatomy, and then there was one hepatic vein which was open, and then we didn't want to intervene. But a liver biopsy suggested that there is Budd-Chiari syndrome, and then hence we had to do a venogram. The IVC was all right. And then when we did a right hepatic venogram, so there was a mild narrowing at the site of right hepatic vein ostium, and there was a good big pressure gradient of 12 mm, 13 mm of Hg, and then so we had to do a balloon dilatation, so we could see a vase there, and then post balloon dilatation, so we can see good flow across the stenosis. So this one complicated case which we came across, so there was, so thrombosis, this is a prothrombotic child, 6-year-old female, where there was thrombosis everywhere. We could see collaterals in the neck. This could be collaterals in the IVC, the femoral veins. None of these veins were visualized, but the child had Budd-Chiari syndrome and had to undergo a DIPS procedure. So what we did was directly punctured the right hepatic vein and the IVC in one go, and then passed a wire, and then we took the transsplenic route to get into the portal vein, and then we dilated the tract, and then we deployed a stent using the transsplenic route. So through the transsplenic route, we dilated the tract, and then we finally deployed the stent across. So this was one case where we could do everything despite the obstruction of all these. So this is just, we can use logical techniques, provided that your technique is very safe and then does not lead to any complications. So radiation exposure is one important thing, especially when you are doing DIPS. So we have evaluated that when we are doing ultrasound guided DIPS, the radiation is very low. We could see that our fluoro time was 23 minutes compared to what was published in adult literature. It was about 19 minutes for cirrhosis and not for Budd-Chiari syndrome. Follow-up imaging is the standard for anything. And then one important thing which we do is do a shear wave elastography, because that can immediately show if your procedure has responded very well. We can see within 24 hours in the day one itself after the procedure, there is good reduction in the liver stiffness, almost 50% reduction in the liver stiffness. And then an increase in the liver stiffness during follow-up may be an indirect indication of recurrence of the disease. And then patency rates, we have seen recurrence occurring within first 12 months, and once a stent or an angioplasty has remained patent for more than 12 months, they have remained stable for long, even up to 7 years. So these are complex, again, challenges. Ultrasound is very important to save radiation, and then so we don't have any dedicated devices for children. We still go ahead and use stents, and then we have not seen it as a limitation as a child grows up, and then there are other limitations which are general for all children. So in conclusion, ultrasound is a very important technique for diagnosis during the procedure and during follow-up, and a proper team management is important for successful outcomes. Yeah. Thank you for your kind attention.
Thank you so much. To conclude the session, may I invite Dr. Vijay Kumar Agarwal to talk about pediatric interventional oncology, highlighting current approaches and outcomes. Welcome, sir.
Good afternoon. Thank you for having me. Today we are going to talk about pediatric oncology. We will discuss what we do in pediatric oncology procedures and our success. I work at two institutions, Le Bonheur Children's Hospital, Memphis, Tennessee, as well as at St. Jude Children's Hospital. As you can see, we do a lot of supportive procedures, typical bread and butter procedures like nerve block, pain management, DVT thrombolysis to support the oncology patients. In addition to the supportive procedures, we also do loco-regional ablation therapy, microwave ablation, RF ablation, cryoablation. We do a lot of cryoablations. Transarterial embolotherapy, mainly for HCC and hepatic metastasis. We do TACE procedures, as well as we have new staff at our St. Jude institution who does yttrium-90 procedures as well. Cryoablation mechanism, I'm not going to go into details, it has already been discussed previously. Cryoablation indication, usually we do cryoablation for lung or pleural metastasis, painful bone metastasis, osteoblastoma. We like cryoablation more over other ablation because it's usually much more well tolerated than RFA, less skin injuries, at least in our experience, and it also depends on individual comfort level, experience level. Some people prefer doing RFA in majority of their cases, which is fine because that's what their experience is and they get great results with that. We did St. Jude study for safety and efficacy of cryoablation of pulmonary and pleural metastasis in pediatric patients. The purpose of the study was feasibility, safety, and efficacy of cryoablation for pulmonary and pleural metastasis. We did retrospective analysis of pediatric solid tumor patients over 4.5 years from 2017 to 2022. The inclusion criteria was less than 7 lung or pleural metastatic lesion on each side from extrapulmonary malignancy and less than 3 centimeter in diameter. Total of 7 patients, total of 40 lesions we included. We performed 20 cryoablation sessions with 2 months to 4.5 year follow-up. All the patients had at least 1 thoracotomy for lung or pleural metastatic resection. Mean size of metastasis was 9 millimeter. Patient demographic, the age ranged from 1 to 17-year-old. The primary solid tumor was ranging from Ewing's to osteosarcoma, hepatoblastoma, mesenchymal tumor, malignant thymic or thyroid tumors. All the patient tolerated the procedure well. The pain score was pretty good. None of the patient had pain score of more than 3 out of 10 during the discharge. As you can imagine, when you do multiple cryos in a lung, there is a risk of pneumothorax, and it did happen in 20% of our patients. We did develop, pneumothorax, but we put pneumothorax catheter for over a few days, and it resolved. One thing we noticed was pneumothorax was more prevalent in patients where we did cryoablation with more than 3 nodules during that procedure. But as I said, pneumothorax resolved without any major consequence. Follow-up imaging, we did CT chest every 3-month interval for first year. 1 patient died with disease progression at 9 months. The rest of the 6 patients had control at ablation site. Median follow-up was 19 months. We used WHO criteria for imaging response. 70% of lesions had complete response, 20% had partial response, and 10% had recurrence and progression of disease. Conclusion, cryoablation is safe and effective durable treatment for local control of pulmonary and pleural metastasis in pediatric patients. Limitation was it was small and retrospective study. In 2021, SPIR recognized our team's work and gave Pioneer Awards to our team. We did microwave ablation as well lately, and we like a little bit more than RFA. The reason is the probe becomes hotter, faster, and there's a less heat sink effect. As you can see in the graph, it becomes faster really quickly. There is less charring, no grounding pads required, and fewer probes. We did total of 18 lesions with microwave ablation therapy in 5 patients, median age of 11 years. All patients tolerated the procedures well. Again, it's a small study, it's a pediatric world, but 5 patients, 18 session is not bad. 40%, like 2 out of 5 patients developed subcapsular hematoma. It was treated conservatively. No further intervention was needed. No other major complication. 4 out of 5 patients demonstrated complete response on follow-up MRIs. This is the one case I'm going to show you guys. We did microwave ablation of 7 liver lesions in one single patient under ultrasound. This is a MEN2A syndrome patient with medullary thyroid cancer, initially diagnosed in 2010. Over the next 10 years, patient underwent multiple therapies, resections, medical therapy, but unfortunately in 2019, patient had recurrent disease and liver metastasis. And as you can see with green arrows, there are 5 lesions over 3 slides on MRI. This is the ultrasound guided microwave ablation we did. We found actually 7 lesions on ultrasound. MRI showed 5, but ultrasound showed 7, which was surprising, but it was there. So we went after all the 7 lesions. And as you can see, the probe of a microwave ablation coming across the lesion and post-ablation changes on ultrasound. Again, 2 more lesions. We went through the probe and post-ablation changes. 3-year follow-up, MR was done. There was no recurrence of disease. Patient was doing clinically well. We did embolotherapy as well. TACE is our go-to therapy for HCC and metastatic liver lesions. And as I said, we have started doing Y90 radioembolization because we have someone our hospital has hired who is pretty good with Y90. We had decent experience with our embolization. All patients tolerated the procedure well. 2 out of 7 patients demonstrated complete response with 3-month follow-up with MRI. And as you can see, radioembolization is gaining popularity. It's a safe and effective radiation segmentectomy procedures. It delivers high dose locally without, injuring the rest of the tumor. If one wants to downstage for transplant purpose, and if you compare Y90 versus TACE, there is more and more evidence that Y90 done properly has more better results than TACE. We do a lot of pain procedures. We did 105 pain procedures over 5 years between Le Bonheur Children and St. Jude Children's Hospital. Mainly we do, most commonly done is celiac axis neurolysis for pain in cancer patients. Results are pretty good, so we continue to do that. This one quick case I'll show, celiac plexus block. We use single needle technique. Some people use double needle technique. After we go across the celiac axis, we inject contrast and make sure contrast spreading across the celiac axis and inject 15 to 20 ml of absolute alcohol. Thank you for your time. Thank you for having me, and it's an honor to be here. And this is why we do this procedure. As you can see, this is permitted with patient. This is we took patient's permission, patient's family permission. This is the patient. This is the mom. This is dad. This is your truly. This is my nurse. This is again my nurse and pediatric surgeon. We work as collaborative team, and it's good to have great results. This patient was suffering and came to our clinic, and just sharing one sweet journey at the end. Thank you.
Thank you so much, sir. With all talks concluded, I request the chairperson to please offer his observations. After that, the session will be open for questions.
The talks have finally come to an end, and I would say that most of the talks were very informative, impactful, and quite energetic. So I can say that this session was very good and productive. So if any questions are there, we can go ahead with the questions, or I can thank all the chairpersons who are sitting here, and as well as the speakers who gave their valuable time and made this pediatric interventions a quite interesting topic. Anybody has questions, then we can go ahead with that. So can we call it a day? Thank you, everyone.